to success. It is the result of preparation, hard work, and learning from failure. With this quotation, good afternoon, everyone. A warm welcome to all distinguished guests, speaker, faculty members, students, and delegates present here. I, Mrs. Ansi Legend, Associate Professor, Sames College of Nursing, feel privileged to welcome you all to this CME. We are truly honored to host this CME on Frontier in Molecular Imaging Advancement in PET Tracers, Theranostics and Clinical Application, organized by Sri Aurobindo Institute of Medical College and PG Institute, and VRM Molecular and Nuclear Medicine Private Limited, Indore. Today's event brings together experts, researchers, future professionals to explore the latest advances and future of nuclear medicine. Coming together is beginning. Keeping together is progress. Working together is success. So now it's time to formally welcome our dignitaries with a sapling. I request Dr. Sanjay Dikshit sir, Dean Medical Education, SAMES, to welcome Dr. Vinod Bhandari sir, Chairman and Founder of Sri Aurobindo Institute of Medical Science and PG Institute, Indore. Welcome, sir. Next, I request Dr. R.R. Vavre, sir, Dean, Sri Aurobindo Medical College, to welcome Dr. Jyoti Bindal, ma'am, our Chief Guest and Vice Chancellor, Sri Aurobindo University, Indore. Welcome, ma'am. I request Dr. Jayashri Tapadia, ma'am, Dean Student Welfare, SAMES, to welcome Dr. Vikram Lele, sir, Director, Department of Nuclear Medicine, Jaslok Hospital, Mumbai. I request Dr. R.K. Jha, sir, Professor and HOD, Department of Medicine, SAMES, Indore, to welcome Dr. Mehak Bhandari, sir, Managing Director, SAMES, and Pro-Chancellor, SAU, Indore. Welcome, sir. I request Dr. Manish Bhagat, sir, HOD, Radiology Department, SAMES, to welcome Dr. Karuna Luthra, ma'am, Director, Department of Nuclear Medicine, Sir H.N. Reliance Foundation, Hospital, Mumbai. Next, I request Dr. Arun Chauhan, sir, Consultant, Department, Nuclear Medicine, to welcome Dr. Anil Kumar Mishra, sir, former Director, INMAS, Professor, Department of Chemistry, IIT Roorkee. Welcome all dignitaries. A person of great insight, dedication, and leadership. It gives me immense pleasure to invite our esteemed patron, Dr. Vinod Bhandari, sir, Chairman and Founder, Sri Aurobindo Institute of Medical Science and PG Institute, to deliver a welcome address.
Our chief guest, Dr. Jyoti Bindal, our guest speakers, Dr. Lele, Dr. Luthra, Dr. Mishra, Dean Student Welfare, Dean Saab, Dr. Chitle, all my faculty members. आप सबका यहाँ वेलकम है सेम्स कैंपस में। और आज की जो CME है इसके सूत्रधार जो लोग हैं मैं उनको सबसे पहले बहुत बहुत कॉन्ग्रेचुलेशन देता हूँ, और मुझे जो सपोर्ट मिला इस प्रोजेक्ट को करने में उसके लिए मैं उनका धन्यवाद भी देता हूँ। और सबसे पहले पीयूष त्रिवेदी जी जो RGVP के पुराने वाइस चांसलर साहब हैं, मेरे स्कूल के बालिना मंदिर के मेरे दोस्त भी हैं, और डॉक्टर A.K. मिश्रा। कोइंसिडेंस था, हम चैम्बर में बैठे हुए थे पीयूष त्रिवेदी जी के साथ। मैंने उनसे कहा मुझे ये बहुत महंगी पड़ती है FD जी, और बहुत सारे पेशेंटों को बड़ा तकलीफ़ होता है। और आपको इसके पीछे एक वाक़या बताता हूँ। 2011 में जब हम पेट स्कैन लिया था, तो पहला पेट स्कैन करा के एक सीए लड़की थी, शी कांट अफोर्ड सेकंड पेट स्कैन। तो मैंने उसको, ऐसे मेरे यहाँ जितने रिलेटिव एडमिट होते हैं तो मैं उनसे पेमेंट नहीं लेता हूँ, पर उनसे एफडीजी के पैसे ले लेता हूँ कि एक के एफडीजी फ्री करा देना। उस लड़की की कराई, शी वाज डिसीज फ्री और कीमोथेरेपी रेगुलरली लग रही थी। तो उसके बाद से मैंने कई सालों तक मेहनत, सोचा, पढ़ा, कुछ पढ़ाई की। पर फिर जब से ए.के. मिश्रा साहब से मिला मैं, पीयूष त्रिवेदी जी के बाद में, वहाँ इनमास में जाके वो इंस्टीट्यूट, आई थिंक जितने न्यूक्लियर मेडिसिन में और रेडियोलॉजी में, उन लोगों को तो जाके देखना ही चाहिए। और वहाँ से जो सीखा और जो समझा, और फिर मिस्टर बाला भी जुड़े हमसे, और जिस तरह ये प्रोसेस बढ़ता गया, गवर्नमेंट ने सपोर्ट किया। आज अपनी सीएमई है। आपको मैं बता दूं कि अपन 15 अगस्त तक, कोशिश जुलाई में ही है ट्रायल रन की, तो पर 15 अगस्त तक अपन कुछ 3 आइसोटोप तो बनाने लग जाएंगे। और उससे जो इस इंदौर को तो ठीक ही, पूरे मध्य प्रदेश में और सेंट्रल इंडिया में बहुत सारी मदद मिल जाएगी। खूब सारी रिसर्च करेंगे अपन। और आज जो टॉपिक्स रखे हैं वो इसीलिए रखे हैं बिकॉज ये सब अपने फील्ड के मास्टर्स हैं, और हमें बताएंगे और सिखाएंगे कि कैसे हम और आगे बढ़ें, क्या कर सकते हैं और किस तरह इस प्रोजेक्ट को और आगे बढ़ाएं। क्योंकि मुझे जितना समझा उसमें इट इज़ ए नॉन एंडिंग प्रोसेस, और जितना कर सकते हो करते रहो। और आप सब आज जो रेसिडेंट्स हो और सब, इनके लिए बहुत बड़ी अपॉर्चुनिटी है ये, आज से जो सीख के जाएंगे तो अपने अपने जो भी आपकी प्रोजेक्ट्स हों या आपका जो रिसर्च का काम हो, उसमें बहुत हेल्प मिलेगी, ऐसा मुझे लगता है। और मैंने भी जितना पढ़ा, जितना समझा उस पर। थैंक यू वेरी मच एंड वेलकम अगेन।
Thank you so much, sir. Now, with great respect and honor, I take this opportunity to invite our esteemed chief guest, Dr. Jyoti Bindal ma'am, Vice Chancellor, Sri Aurobindo University, to kindly come forward and deliver welcome address. Welcome, ma'am.
Very warm good afternoon to all of you, and it's a podium I'm taking with mixed feelings, being the host and the chief guest. So on behalf of Sri Aurobindo University, I would like to really extend a very warm welcome to all the esteemed guests, reverend scientists, faculty members, colleagues, students. It's genuinely a privilege, and I'm so much humbled with this honor, and I would especially like to thank our founder, chairman, and a very close friend, Dr. Vinod Bhandari, and Dr. Mishra, who gave me this opportunity to speak at such a forward-looking conference, a conference which embodies fusion of science, technology, but most importantly, hope, which Dr. Bhandari just now spoke about. The frontiers in molecular imaging, advancement in PAT tracers, clinical applications, and theranostics. As both Professor of Gynecology and Vice Chancellor of this institute, I've seen firsthand how the technology reshapes our understanding of the disease. But even before I go and reflect on the science, allow me a moment to talk, and words fail me, honor the man, the person whose vision makes our gathering today not only possible, but profoundly meaningful. Our founder chairman, Dr. Vinod Bhandari, and the father of this cyclotron project. So I would like all of you to give a big hand to this friend of mine. You know, Dr. Vinod Bhandari is a man of rare insight and scientific foresight. he envisioned a center, and I was just now talking to Dr. Karuna about our center today. The center which will not only keep pace with the world, but actually lead it. He saw the potential of molecular imaging and theranostics decades before it became mainstream. We just heard that the thought came to his mind long back. And remember, his passion is never only for infrastructure. He believes in 3 P's. He believes in people, he believes in patients, but most importantly, he believes in possibilities. He sees a person, he doesn't see a person, he sees the possibility of that person, and that is what makes him really a visionary leader. I still recall a conversation with him when he said, if we can see the disease early and treat it precisely, we do more than heal. We give people their lives back. And that is the spirit which is alive in every scan, every tracer, and every life which is touched by this institute. So once again, Vinod, we are lucky to have you with us. Molecular imaging, of course, has transformed the way we approach diagnosis and therapy, especially in oncology. And the evolution of PET tracers from basic glucose analogs to highly specific ligands, not a scientific triumph alone, but also interdisciplinary collaborations. As I was just asking Dr. Karuna, so from the field of radio diagnosis, she chose or was destined to become a nuclear scientist, and as I said, interdisciplinary collaboration. So we now actually with all this, we don't only see the function, the metabolism, but we see the behavior of disease. And again, as a gynecologist, the various possibilities in gynecological malignancies is very, very exciting, very humbling. And we can see, recurrences earlier, etc. But especially, I'm impressed by where theranostics is taking us. And I think your Society of Nuclear Medicine and Molecular Imaging in 2023 in Chicago, when they had the theme of eye on the patient, that was the first time an award was given recognizing a novel theranostic pair for pancreatic cancer. And that is when the world first thought that this was something out of universe. And so I must end up by saying that institutions like ours, and it makes the responsibility of all our faculty and students here, we must rise to the occasion, not only to innovate, but to educate and to train the next generation of radiochemists, nuclear medicine physicians, oncologists, and scientists who will take this legacy of our founder chairman, Dr. Vinod Bhandari, forwards. And I do see all that potential in this room alive in front of me. So we have great hopes from all of you, and let us take the unwavering belief of our founder chairman and let us use this power of science to serve humanity. Let us collaborate, let us question, and let us innovate. But never forget why we are doing this work. Don't forget person as a human being. Don't forget the reason behind all this evolution. Once again, thank you so much for being here. And like me, I'm sure we all are going to learn from our learned scientists today. Thank you so much.
Thank you so much, ma'am, for motivating us. Now we move forward with today's session. The first session will be on the topic Role of Nuclear Medicine in Cardiology and Neurology Practice. by Dr. Vikram Lele, Sir, Director, Department of Nuclear Medicine, Jaslok Hospital, Mumbai. The chairperson for the session will be Dr. Pradeep Gupta, Sir, HOD Cardiology Department, Sri Aurobindo Institute of Medical Sciences, Indore, and Dr. Priyusha Bagdare, Associate Professor, Medical Physics, SAMES. The introduction of the speaker will be given by the chairperson, and rest the session will continue.
Good afternoon, ladies and gentlemen. At the outset, I would like to extend a very warm welcome to each and every one of you in our symposium. We have got the three very exciting sessions. And the first session is on nuclear medicine, a problem-solving tool. Whosoever is coined this topic or entitled this topic is absolutely true. The nuclear medicine in cardiovascular sciences just not for the risk stratification, for diagnostics, and as a therapeutic tool. Especially for cardiologists, we see very commonly that a critical stenosis, either a lady circumflex or circ, and the ejection fraction is 35. We can fix the artery. But we don't know whether we are really benefiting the patient or not, whether the supply territory is scarred or it's a reversible myocardium. So our patient is going to benefit or not, that's the ultimate aim to know. So the nuclear medicine just not helped us only in viability studies. You can have whole plethora of information from myocardial blood flow to myocardial inflammation, infiltration as in sarcoid and amyloid. And with the help of AI, these algorithms solve the mysteries and provide the help much faster and much effective. To learn more about on all these aspects and the role of nuclear medicine in cardiology and neurology, let me present to all of you Dr. Vikram Lele, a legend in the field of nuclear medicine. He has got a vast experience of more than 30 years. Currently, he is a director of the nuclear medicine department at Jaslok Hospital. He did a lot of pioneer work in cardiology and neurology, especially in neurology pertaining to Parkinson's. And he is contributed immensely in the academics, published so many papers not only in Indian and international journals. He is the ex-president of the Association of Nuclear Physicians of India. With this brief introduction, I would like to welcome Dr. Vikram Lele to give his talk on role of nuclear medicine in cardiology and neurology. So ladies and gentlemen, bring both the hands and welcome Dr. Lele. Floor is yours, sir.
Where is this stop on this? Next is here. Okay.
सर इधर नहीं हो रहा हमारे लैपटॉप में, उनको बोलो वहाँ से. या नेक्स्ट नहीं हो रहा.
In the last 34 years, which I have been practicing nuclear medicine in this country, I have visited several centers, given talks, lectures, orations sometimes. But when I visited Indore, I have come there before long years, many years back. But when I came here today, for the first time in my life, I am overwhelmed. I am overwhelmed what the vision of a single person, a single dedicated person can achieve. I have seen the fantastic setup over here where one man has decided that he brings into this city several aspects of education, be it engineering, be it medical education, be it clinical medicine, dentistry, nursing. Look at the canvas on which this individual has put in the infrastructure, not sparing any expense and making available the state of the art, the cutting edge of technology for the residents of this city. So for the first time I am seeing a world-class institution which will not only benefit Indore, but which will benefit our whole country. And as the Vice Chancellor said, he will not only be a leader in India, but with the amount of work which is being done in bariatric surgery. It was amazing to see the training programs which are going on. This is going to be a world leader, not only Indian leader. And I am really humbled and proud to be called to address a gathering in this institution. So the nuclear medicine, I also saw the setup when I went there today. It's a class setup. You have a very big therapy ward with 5 beds. You have an absolute state-of-the-art digital PET CT, and you have a SPEC CT. So every aspect, every scan which we do in nuclear medicine, not here but abroad, can be done here. And you are now putting up a cyclotron, and you are going to get available all the esoteric isotopes which we can use to diagnose different human diseases. Some of them are not even available to me in Mumbai, and the Indore people are going to get them with the help of this fantastic cyclotron, which will, I believe, start working in August of this year. So all the best to this man with vision and to all the people of Indore. So I'll be talking about the role of nuclear medicine in cardiology and neurology practice. So nuclear medicine basically, as you know, uses radioisotopes, and we tag them with different compounds which have affinity for different organs. The isotope acts as a torch. It will go wherever the compound takes it. If I want to study the brain, I tag it with an isotope, with a compound which goes to the brain. If I want to study the heart, I tag it with a compound which goes to the heart. So I can study function of various organs. And as you know, function is altered very early before any structural abnormality takes place. So that is the strength of nuclear medicine, that we can pick up altered and disordered function long before any structural abnormality comes in. So in cardiology especially, we have a lot of things which we can study. We can study the myocardial perfusion, we can study the myocardial function, that is the pumping power, which is done very well by echo. But in this single study, we can study the perfusion, the blood supply to the heart, which territories are getting adequate blood or not. We can study the myocardial metabolism. The heart is a very voracious organ. It eats everything which comes its way. It eats glucose, it eats fatty acids, ketones. So it picks up whatever there is available. And we have tracers to study this metabolism. We can see what particular substrate the heart is picking up. And as the chairperson said, viability is one very important aspect which I will be talking about. We can study the innervation of the heart. The heart has sympathetic innervation, and we have tracers which we can map the sympathetic innervation which gets altered in disease. And if we show that there is an altered sympathetic innervation, we can predict whether this person is going to develop fatal arrhythmias in future, and then we can take preventive measures. Now, as the chairman also said, we have tracers where we can see inflammation of the heart, sarcoidosis. We can see if the heart is infiltrated with amyloids. We have tracers which are very cheap, pyrophosphate. We can show whether there is a ATTR, it's a specific amyloid infiltration of the myocardium for which there is therapy available. So we can diagnose this very well with nuclear medicine procedures. So these are the main tools which we use. Two technologies are used. One is called SPECT, or single photon emission computed tomography, and one is called PET, or positron emission tomography. Now, when we combine the functional imaging with CT, we get an extremely powerful tool where we have anatomy combined with physiology. So, what you see at the top left is a very dedicated cardiac SPECT machine which we have. It's a solid state camera which is used to very sensitively pick up myocardial perfusion. The lower one to the left is the standard SPECT CT camera which all of us are using for diagnosing various diseases, and on the right is the PET CT what we have, and you, as I told you, have the digital PET which at the moment is the state of the art. So, why do you require myocardial perfusion imaging? You want to see the blood supply of the heart, and what we have to imagine now is that there are several imaging techniques available to study coronary artery disease. Coronary artery disease is a very major disease which affects Indians, probably because we have high incidence of diabetes, and we have extensive involvement of the coronaries, especially at younger ages. We have people as young as 20 coming with coronary artery disease. So what do we want to see in coronary artery disease? We want to know whether there is atherosclerosis, whether atherosclerotic plaque is coming up. So that we have the MDCT, which will give you the calcium score. The calcium score is a good surrogate for an atherosclerotic burden in the heart. You want to study the anatomy, coronary anatomy. You have again coronary CT with contrast, and you have the conventional angiogram. If you want to study the perfusion, then we have nuclear medicine, where we have the myocardial perfusion scan. There are several aspects of it which I'll talk a little bit. So why in myocardial perfusion scan, we are using a tracer which is extracted by the myocardium in proportion to the blood flow. So when we make the person exercise, the blood flow to the heart increases. So at the peak exercise, we are injecting the isotope. So it will go into the myocardium in proportion to the blood flow. The areas of the myocardium which are supplied by stenosed arteries will get less blood flow, while the areas which are supplied by normal arteries will get normal blood flow. So the tracer will go normally to the normal areas, it will go less to the stenosed supplied areas. So we will pick this up as a perfusion defect. So that basically is the principle of myocardial perfusion imaging. And when this perfusion defect is very severe, we can classify the scans which we see, which I'll be showing you, into various patterns, and we can give a prognosis. So who will need a myocardial perfusion scan? You will say if a patient has got angina, we know that the heart is getting less blood. So I just do an angiogram and forget about it. Why do I need all this? As you know, a classic angina is pain which is substernal. It occurs on exercise. It's relieved by rest or nitroglycerin. But many of the chest pains are not so typical. They're very difficult and many times to make out is it really angina or not. And then in this situation, we do this scan to find out if there's really an ischemia going on in the myocardium or not. And to do that, we do a stress test, a simple stress test. All of you have done treadmill stress test. If it is strongly positive, you know there is a ischemic heart disease going on. But many times, patients have an abnormal baseline ECG. They have a left bundle branch block, they have a left ventricular hypertrophy, where a patient with WPW syndrome, where the baseline is so abnormal, how are you going to diagnose further abnormality on that? So in this situation, a myocardial perfusion scan is very necessary. Women, in women there's a very high false positive treadmill test. For some hormonal reasons, their ST segments go down. ST segment going down is a diagnostic criteria for abnormal stress test. But in women, many times it is positive without any coronary artery disease. So in them, we have to do MPI to find out whether there is a real ischemia going on or not. Many times patients are very elderly and some of them have severe arthritis. So they are unable to do your regular treadmill, which you usually use to diagnose ischemia. That's where we use pharmacological stress. We call it as a lazy man stress test. We inject adenosine, which directly dilates the coronary vasculature. Instead of the person having to exercise and the cardiac muscle will dilate its arteries. So we get the same information without the person having to exercise. Then you have asymptomatic or mildly symptomatic patients with high risk factors. You have a very strong family history. You have diabetes, hypertension, high cholesterol. You want to know whether this person has a subclinical ischemia going on. That's where you're going to do myocardial perfusion. Patients who have known coronary artery disease, many times patient comes with triple vessel disease. Some of the vessels are 70% narrowed, some are 80%, some are 60%. You want to know what is the significance of all these stenosis. So when we do a perfusion scan, we will show which territory is having ischemia and which territory needs to be tackled. So we can tell the culprit lesion in the abnormal angiogram. Post-angioplasty, patient again comes with symptoms. We want to know if restenosis has occurred. Again, you do myocardial perfusion scan. Post-bypass surgery, if the grafts are patent, patient is coming with vague symptoms. You want to know if how is the perfusion, you do MPI. After infarct, we want to see viability. As the chairman said, many times the person comes with a very low ejection fraction, and to submit him to a bypass surgery with a dead myocardium, it's like flogging a dead horse. But if you show that the myocardium is alive, then you must do everything possible to open up the vessel and revive the myocardium. And we can, with the help of FDG PET, do that very well. So this is a typical myocardial perfusion scan where we stress the patient and we take two images, one at rest and one at stress. The top image is at rest, the lower image is at rest. So you can see the heart has been sliced in the short axis, vertical long axis, horizontal long axis. You can see the top row, the heart should look like a complete circle. It should look like a donut, and you can see everything appears nice and pink. This is a typical normal myocardial perfusion scan. If you get this pattern in a patient who is having chest pain at a good high level of exercise, this person is very low risk. Though there are some caveats which I'll talk to you about later, this pattern in a symptomatic patient confers a very low risk of future coronary events. On the other hand, here is a patient you can see on the stress image at the apex, there is a perfusion defect, which on the resting image, I don't have a pointer here, but I think it's there. You can see this is the apex. You can see on stress there is a perfusion defect, and at rest it becomes completely normal. Again here, this is the apex which is showing a perfusion defect. On rest it becomes completely normal. And inferolateral wall also, there is a defect which improves. So here is a classical case of inducible reversible ischemia. And when you get this pattern, you know that there is ischemia going on in the myocardium. It's not changing. So with the help of our scans, which we can classify the patient into various patterns. We can say that the person has a low risk pattern, a high risk pattern, and we have criteria to call this. What I showed you just now, the first case was a low risk pattern. There was no perfusion abnormality. Then you have a high risk pattern where there is a large defect which is involving more than 20% of the myocardium, and there is a fall in the ejection fraction, there is uptake in the lung. And these patients have a very high annual cardiac event rate of almost 8 to 10%. Those who have a normal scan have a less than 1% cardiac event rate. So doing a myocardial perfusion, you give the immediate risk stratification at who is at high risk for developing future event. And there was a very important study done by Hakamotovich where they found out the importance of quantifying the amount of myocardium which is ischemic. And they showed that if you have more than 12.5% of the myocardium which is ischemic, these patients tend to do better with interventional strategies, while those patients who have less than 12.5% of the myocardium ischemic do better with medical management. So you sort of get a gatekeeper function, who should go for a interventional strategy and who should go for a medical management. Another very important thing which we are realizing now is this concept of microvasculature. You can see on the left hand side is a coronary angiogram which is seeing the epicardial coronary vessels. You can see the LAD, the circumflex and RCA very well. On the right hand side is a person who has been injected with a dye and his heart has been taken out. and you can see the humongous amount of microvasculature which is there, which is not seen at all on the angiogram. So this is the amount of microvasculature where the disease will start, which the epicardial coronary angiogram is blind to. So how do you pick up disease which affects this microvasculature? And nuclear medicine has a very important role in this arena. What we interrogate, there are two important parameters to interrogate the microvasculature. One is called the coronary flow reserve, and the second is absolute quantification. With the help of tracers, PET tracers, like ammonia, rubidium, and now a new tracer called fluoperidase. Ammonia is going to be available with your new cyclotron. Fluoperidase will also be available. We will be able to quantify how much ml per gram per minute is the flow reaching the heart. And we can calculate the coronary flow reserve. What do you mean by coronary flow reserve? The heart is able to increase its blood supply 3 to 4 times above the baseline in response to stress. This ability to increase the blood flow in response to stress is called the flow reserve. Many times when there is severe dysfunction of the microvasculature because of diabetes, because of many other conditions, this cardiac flow reserve gets attenuated. The heart is unable to increase its blood supply, and we can easily show that this flow reserve is reduced by doing ammonia studies or by doing rubidium studies. And when you have PET successful in flow quantification and coronary flow reserve estimation, and we now have enough data quantifying the normal flow reserve across various states of cardiomyopathy, of ischemic heart disease, of hypertension, in syndrome X. So we have a well-established values for normal coronary reserve and abnormal coronary reserve with the help of PET. And we can actually see, and the important thing is when you do a myocardial perfusion scan, what you're looking at is a relative perfusion. If one artery is more narrowed than the other, the isotope goes less to that area. But if all the arteries are equally narrowed, the isotope will go equally to all these areas equally badly. So the final image looks normal because there is no differential reduction in the function. So this is called a balanced triple vessel disease, which on a MPI, myocardial perfusion scan, which we normally do, can be missed. You can miss a balanced triple vessel disease. Though again, we can see the ejection fraction fall, we can see the transient, there are other ways of getting around this and not looking only at the perfusion. But when we do a ammonia study, we are getting absolute flow. We know that on stress, the hearts get so many ml per milligram per minute. And we know that the flow reserve is more than 2.5. So if you are looking at a normal looking perfusion, but you have a flow reserve which is less than 2.5, and you have an absolute value which is very low, you know this patient has triple vessel disease, though the image looks, perfusion image looks normal. So that's the strength of PET, where we can diagnose, where the apparently normal looking perfusion, we can diagnose the abnormal perfusion by quantifying it. And this study shows that the flow reserve is very important prognostic value. At the top, the red one shows you the cardiac mortality rises high when the flow reserve is very low. At the bottom green line, the cardiac mortality over years is negligible when the flow reserve is very high. And with PET, we can get the flow reserve non-invasively in everybody. For what the cardiologists now do is they calculate the FFR, the fractional flow reserve, by putting in a catheter. And they look for the pressure drop between the aorta and across the stenosis. And a value of 0.8 and below is considered as abnormal, that there is an abnormal fractional flow reserve, and this is considered as a physiologically significant stenosis. This requires the catheterization. With the help of PET, non-invasively in everybody, we'll be able to give you global flow reserve as well as regional flow reserve in the distribution of individual coronary arteries, and that will be very helpful in management. Look at this. This person has, look at the upper limit. All these images look absolutely normal, stress and rest. So if I had done only the perfusion, I would have called this a normal study. But I have quantified it. And look at the quantification, the myocardial blood flow reserve is only 1.4. MFR is myocardial flow reserve. The normal flow reserve is more than 2.5. Here the reserve is only 1.4. This is a grossly abnormal study. But looking at the images, it looks completely normal. So PET perfusion is going to change the way we are looking at myocardial perfusion because of the strength of quantification. And the FFR, the fractional flow reserve, which you measure, is heavily dependent on the global flow reserve. If there is a huge amount of microvascular dysfunction, then the FFR value is affected by that. So in future, the flow reserve calculated by nuclear medicine technique is going to be an extremely important, even better than the FFR to make management decisions. The importance of function versus anatomy was highlighted by the FAME study. Previously, we thought that a significant stenosis is when the stenosis is more than 50%, and a critical stenosis is when it is more than 75%. Now, when the FAME study showed, when they started doing fractional flow reserve, you can see that 50 to 70% stenosis, which is the range where you have significant stenosis clinically, 65% of the lesions were not functionally significant. So by the FAME criteria, when the stenosis on the angiogram was between 71 to 90, which is a critical stenosis, 20% of the lesions were not functionally significant, even though the stenosis looked very significant. So this study showed that anatomy alone is not enough. The lesion may look critical, but by doing functional studies, we can avoid unnecessary angioplasties. Do only plasties on those who have a functionally significant coronary stenosis. By FFR is working very well now, but when the myocardial flow reserve comes with the help of ammonia, it's going to be very useful because there's no need for any invasive strategy. You can do it in everybody who comes to you. So this is the importance of the FDG PET. What you're seeing here is a person who's got a massive infarct. You see at the top, it should look like a complete circle, but you can see the anterior wall, the septum, and the inferior wall all show severe perfusion defect. The question was, is this myocardium viable or not? So we have injected FDG. FDG is fluorodeoxyglucose. The myocardium which is alive laps up glucose. Myocardium which is dead doesn't pick up glucose. It is not metabolically active. So if this muscle is alive, it will pick up glucose. So when we give injection of glucose, look at all this. The whole muscle over here, anterior wall, septum, inferior wall, picked up glucose. So this was live myocardium. You must go ahead, revascularize, and after revascularization, you can see the whole perfusion image is looking completely normal. So making decisions about revascularization in a patient who's got a very low ejection fraction is made very easy with the help of FDG PET. There are other modalities also. MRI, cardiac MRI is also excellent for looking at viability. But currently, the most sensitive technique for viability is FDG PET. It's better than MRI in sensitivity. But what the studies showed that we want to predict who's going to recover the function after revascularization. And there, the FDG shows that it is viable. Whether the function will improve or not depends on several factors. It depends on how long the myocardium has been hibernating and how good your revascularization surgery has been, whether there has been any peri-infarct changes. So if you want to know, is the myocardium viable or not, currently FDG is the most sensitive method to know that decision. So going from the matters of the heart to the matters of the brain. Now nuclear neurology again has been around for several years. In fact, it was the first modality which helped us to gain insight into the functioning of the brain. All the perfusion, the penumbra, when a patient has got an infarct, he has a penumbra and an umbra. So the first studies which were done were based on nuclear studies, which then of course the MRI came, and now the MRI is the gold standard. But it was based on the knowledge gained from perfusion studies done by PET. So currently we have a lot of role in cerebrovascular disease. The role has been taken over almost completely by MRI. But we have a certain role in called cerebrovascular reserve. Just like you have a cardiovascular reserve, the brain also has a cerebrovascular reserve. When we give intravenous Dimox, the brain arteries dilate, and then we inject the tracer. So all the arteries are dilated, the tracer goes very nicely. But there is a stenosis in the carotid artery. You want to know how significant that stenosis is. That stenosis will prevent the blood from reaching when we are giving Dimox. So after giving Dimox, if you find that there's a significant fall in the uptake of the tracer in the brain, you know that this stenosis is significant and you must tackle it, you must open it. So this is one niche which is still used by neurologists. Neurodegenerative disease is the very important utility for nuclear medicine. We can diagnose dementias, dementias of several types. All of you know about Alzheimer's dementia, frontal lobe dementia, Lewy body dementia, and we can diagnose Parkinson's disease and several Parkinson's plus disorders called PSP, MSA, and CBGD. I don't know if there are neurologists here, but this can be a difficult problem to diagnose, to distinguish between these various Parkinson's-like syndromes. Then we have a very important role in epilepsy, where in an intractable epilepsy, we can localize the seizure focus so that the surgeon can go ahead and remove that focus and give relief to the patient. Brain tumors, patient has been operated, he's been given radiation, he comes back again with symptoms of raised ICT. You want to know whether it's a recurrence of the tumor or is it just raised edema in the brain. MRI is excellent for this, but many times the MRI cannot distinguish between the two. That's where we come in to distinguish between recurrent tumor and radiation necrosis. We have excellent tracers for that. We have amino acid tracers like fluoroethyl tyrosine. We have fluorodopa, which goes to active tumor. It doesn't go to necrosis or edema. So you can distinguish them very well. We have a very important role in paraneoplastic syndromes, patients who are coming with neurological symptoms, and they are usually caused by some occult malignancy. So we can pick up this occult malignancy and show that this is the cause of this paraneoplastic syndrome, which may be like a limbic encephalitis, which is very difficult many times to point out. Finally, psychiatry. Psychiatry is a very descriptive thing. If a patient says, I'm hearing voices, there's no way you can prove or disprove it. You have to believe what he says. But we have to have some method to objectively see if something is really going on in the brain. So now there are several studies where we have seen patterns which are abnormal in depression, in schizophrenia. We have FDG patterns which are quite abnormal. In depression especially, the whole brain metabolism goes down. So if a patient is depressed, many times I said, नाटक कर रहा है, कुछ नहीं है. When you do a FDG PET, you see the whole brain is metabolically down. He is genuinely depressed. He is not pretending. So we have objective evidence of what is happening. This is a normal brain PET with FDG glucose. We have sliced the brain from the bottom to the top. This is right, this is anterior, this is left, this is posterior. Look at the nice caudate nucleus, thalamus. The brain, normal brain looks like this. So this is the symmetrical, homogeneous uptake in the brain. Now, in a person who's got a memory loss, all of us have memory loss. I am 64 now, and many times I forget why I am coming into this room. Many times I forget, chashma kidhar hai? It's there on my head. So these are what are called as age-associated memory impairment. It doesn't mean anything more than that. So in a normal person, you have what I showed you just now, normal appearing brain. In age-associated memory impairment also, the brain looks completely normal. And then you have this condition called mild cognitive impairment, where the patient is having disability in various aspects of the cognition. It could be memory, it could be recall. So some aspect of his cognition is down, and he's worried, am I going in for a dementia? That's where when you do a FDG PET and you find completely normal, you reassure him, you're fine. There's nothing wrong. You can enjoy your memory loss. Sometimes it is useful. But if you have a mild cognitive impairment and you have an abnormal this FDG PET, this is a red flag which is raised. 50% of these people who have abnormal metabolism, hypometabolism in the parietal cortex, and clinically they have mild cognitive impairment, they will progress to Alzheimer's disease in future. So this becomes again a gatekeeper who has no future probability of Alzheimer's and who is likely to develop Alzheimer's. Then early Alzheimer's disease, we start getting a typical metabolic signature of Alzheimer's disease, where we get bilateral parieto-temporal hypometabolism. And then late Alzheimer's disease, we get frontal and parietal. So we can have this classical metabolic signature of Alzheimer's disease. Here is a 65-year-old male with loss of memory, maintained insight into the illness, PET scan requested to rule out Alzheimer's disease. What do we find? Severe bilateral parieto-temporal hypometabolism. This is a normal. I'm giving you a reference slide. Then when you get this pattern where the sensory motor cortex is spared and you're getting a bilateral temporoparietal hypometabolism, this is Alzheimer's disease. And you can tell the patient it's a death sentence. When you're told Alzheimer's disease, it's a horrible thing. But I've had doctors coming to me practicing and becoming slow in their diagnostic ability. And when we showed them that, yes, you have a serious problem, many of them voluntarily stop their practice, which is nice of them. Otherwise, they'll continue to practice and have errors in their diagnosis. Here's a patient who comes, 70-year-old male with anxiety, irritability, personality changes. Now in that last patient you saw parieto-temporal hypo. Here the parietal temporal is not too bad. Here is the frontal which is severely hypometabolic. This is a frontal dementia. And there are several varieties of frontal dementia called behavioral variant, semantic variant, which we can show with the help of FDG, dissect them out, and you can help the neurologist quite well. And finally, I think last 3-4 minutes, Parkinson's disease. That is something where nuclear medicine has a very major role to play. Parkinson's disease, as you know, comes with bradykinesia, rigidity, tremor. And many old people are bradykinesia, they are slow. They have some old tremor and they look sort of slowed down. Do they have Parkinson's disease or not? And how do you know that? It's usually a clinical diagnosis. And what is important as the clinical diagnosis of Parkinson's disease in the best of hands can be wrong in 20% of patients. And what we have here is a study called dopamine transporter scan or TRODAT scan, which you have been doing in Indore, I believe, for some time. In Parkinson's disease, there is a deficiency of dopamine transporter. And we can image this dopamine transporter with TRODAT. What you're seeing here, you can look at the top, that's my brain. We introduced TRODAT first time in the country several years back, and I was the first guinea pig. I injected myself and luckily everything looked normal. This is what you are seeing, the caudate and the putamen. So when you have a symmetrical uptake of the transporter, it is a normal person. And look at this. This is a person who has got reduced uptake in the left posterior putamen. This is the right posterior putamen, right caudate, left putamen. This left putamen is down. There is no uptake in the left putamen. This is Parkinson's disease. So many times in the past when they were recruiting patients for therapy for Parkinson's disease, as many as 20% of these scans were normal. The neurologists were recruiting them and the neurologists were calling them as Parkinson's based on strict criteria, top neurologists. And 20% of these scans, 15 to 20%, were completely normal. So this term was coined, SWED syndrome, scan without evidence of dopaminergic deficit. Now these patients do not progress. Parkinson's disease is a progressive disease. They will become abnormal, more and more and more abnormal. So they require treatment. But these SWED syndrome patients, they don't progress and they don't require treatment. So you can see 15 to 20% of patients who look clinically Parkinson's are normal. They are not Parkinson's disease. That's where the neurologists started using this scan to make diagnosis. And Parkinson's disease has several mimics. You have many drugs which can cause Parkinson's like picture. And you want to know, is it Parkinson's disease or is it drug induced? You do a TRODAT scan. In the drug induced Parkinsonism, TRODAT scan will be completely normal. If it's a essential tremor, you know, many people have a tremor without Parkinson's disease. Again, the Trodat scan will be completely normal. While in Parkinson's disease, the putamen is down. So this test is now well established for diagnosing Parkinson's disease. And here we also use fluorodopa, which is a PET tracer, which again will be available to you very soon. PET tracer, you do the scan in 10 minutes. Trodat, you have to make the patient lie for about half an hour to 35 minutes. Imagine, these are all elderly people. They can't lie still for 35 minutes. They are shaking. And you are going to get a lot of artifacts. While in F-DOPA, even 5 to 8 minutes, they have to lie down. So F-DOPA is now has almost replaced Trodat in most of the centers. Here was a 69-year-old male presented with gait disturbance. He was started on Syndopa, assuming he's got Parkinson's disease. And then he was sent to us for the scan. Look how normal the scan is. There's absolutely no dopaminergic deficit here. This is not Parkinson's disease. And you can stop the treatment and avoid unnecessary side effects of the drug. And then with the help of FDG, you can further dissect this Parkinson's disease between MSA, PSP, CBGD. I won't go into the details, but the combination of the DOPA and FDG helps the neurologist to dissect between different types of Parkinson's plus syndromes. And in epilepsy, the focus of seizure is usually hypometabolic. So if you have an intractable seizure, here you see the left temporal lobe is hypometabolic. So we are able to say that this is the seizure focus. And when it correlates with the EEG, you have a very strong evidence that this is the focus which should be ablated surgically. Limbic encephalitis, we get typical patterns of hypermetabolism in the temporal lobe. Tumors, I'll be just showing you one or two. Dr. Luthra will probably tell us more. We are using a fluoroethyl tyrosine PET. Here was a patient who had a glioblastoma. He had a surgery and radiation, and he came with symptoms again. MRI was not very useful because it did not show the typical pattern of a recurrence versus necrosis. When we did a FET PET, you saw this intense uptake. This is viable tumor. It's as simple as that. It goes to viable tumor and it helps us to distinguish between the two. And finally, the last two slides. Here is a patient with severe depression. You can see that the whole brain is down. Only the caudate nucleus, thalamus and basal ganglia are intensely hypermetabolic. Rest of the cortex is down. So we have an objective evidence of a metabolic abnormality where the only evidence in depression is what the patient tells you. And you have these clinical scales. But now here you can see the cellular function. And finally, this is the study I did when I was in Germany in 1986. There was a lot of interest in meditation. You know, in India, meditation is a big thing, and it is supposed to cure everything possible. So we wanted to see, does something happen in the brain when you are meditating? So we brought patients from Germany. I was in Germany at that time, and we studied them during a basal state and during a deep meditative state. We injected them with FDG while they were just relaxing. Then after some time, we again injected them FDG when they were in that deep meditation. And we compared. And we found some interesting things. Here you look at this scale here. The yellow means there is a lot of glucose metabolism. Blue means there is no glucose metabolism. This is the baseline. And when the person goes into meditation, you see more and more, most of these yellow things have gone down. So this was like a global reduction in the brain metabolism. But mind you, there was a caveat to that. When we studied meditators who were novices, who had just started meditation, we found that the whole brain lit up. It became hypermetabolic. And those who were extremely experienced meditators, this is what we found. During meditation, everything went down. And those who are intermediate levels, we found mixed pattern. So it only means that the brain becomes adapted to the same task. And it's not because of meditation, it's because that you are adapted to a task which you do again and again. So if you start playing a video game, your brain will light up because you are using all your neurons. When you become an expert at the video game, your brain doesn't light up. It's the same between baseline and meditation. But the people over there were very happy. They said, see, this is happening. So we still don't know the exact, this is a finding that with more and more tasks, your brain adapts, it becomes more energy efficient. That's the only conclusion we can make of that. I think that is my last slide. Thank you for your attention.
Now are the studying inoca and minoca. That means ischemia with normal coronary arteries and myocardial infarction with normal coronary arteries, as we are unable to assess the coronary blood flow reserve. So I think in this area, this is going to help us a lot, and 20% of our what we think is non-angina, basically they are suffering from microvascular angina. So this will help us a lot in understanding in these patients in future when we get these studies. And I would conclude by saying that this modality is grossly underutilized. So I would request by these enlightening lectures, we all in future would be able to utilize it more and more to benefit our patients. Thank you. Any question from the floor? Any questions or comment?
Hello.
Imaging like CCT or MRNGO, we are able to pick up only the large vessels or the medium vessels or some small vessels. The capillaries and the endothelitis basically, which basically like in myocarditis, like in any connective tissue disorders we are having myocarditis. We want to pick up enteritis or any other small vessels or the micro vessels. Can these imaging can help us in identifying vasculitis as early as possible so we can therapeutically intervene at early?
Yes, currently FDG PET is quite good in detecting vasculitis, but again it is in the large vessel and the medium vessel vasculitis at a stage where the CT is not showing anything.
Yes, sir.
We can show intense uptake. There's another agent called FAPI, fibroblast activation protein inhibitor, which also shows very beautifully inflammation of the arteries at a stage where all other modalities are negative. So these two are powerful tools. About myocarditis, nuclear medicine is being used very extensively, but as you see, the heart muscle picks up glucose. So if we give a normal person injection of glucose, the heart will glow. So we have to use a very specialized protocol to suppress the glucose uptake of a normal myocardium by starving the patient for 18 hours, by not giving any carbohydrates, by giving high lipids. Then the heart will choose lipids over glucose. In that situation, there will be no uptake of glucose in the myocardium. And then in that, after good preparation, if you find uptake in the myocardium, this is myocarditis. And you can also use agent called DOTA-NOC, which normally doesn't go to the heart. It goes to inflammatory cells. So in the DOTA-NOC PET, if you see uptake in the myocardium, this is myocarditis. So we can inject, but about small vessels in the kidney, not possible because the resolution is not so good to pick up capillaries.
Okay, sir.
There we can, in the heart, we are not visualizing the capillaries. We are actually seeing the flow and quantifying it. So something in future may occur. We will be able to quantify the blood supply to the kidneys and infer that there is a vasculitis going on.
So just one last thing. So like in large vessel vasculitis where the predominantly involvement is of the vasa vasorum, like the aorta, we have the small blood vessels which supplies the aortic wall. So the aortic wall, like in Takayasu or in giant cell, we get an uptake on PET. Like we usually do PET for the diagnosis of either Takayasu arthritis or a giant cell arthritis. So with these imaging modalities, can we pick up those vasa vasorum involvement?
I don't think the resolution is that good. We'll be able to show you the global involvement of the whole wall which is inflamed. I don't think we can be that minute.
Sir. Okay, thank you, sir.
Sir, all our life, first of all, I need to compliment you on the beautiful and very learning curve we got. All our lives we've been believing that depression is a subjective symptom. For the first time today, at least I learned that there is an objective element and modality. Is there something like that for pain? Because again, that's again a subjective symptom.
I mean, several studies have been done, and we have seen various patterns. And studies have been done with acupressure to see whether the pain before giving acupressure, after giving acupressure, the thalamus lights up in pain.
Okay.
The limbic cortex lights up in pain. And if your pain relief is effective, these things go down.
Also the metabolism
will go down.
Okay.
There have been several studies which have, but these are expensive and these are all research. So they are not got into routine. Nobody wants to spend 20,000 rupees to see,
if the pain is genuine.
Right.
Also, sir, you spoke about balanced triple vessel disease.
Yeah.
So in that you said the isotope would be equally taken by all the vessels because everything is narrowed.
Right.
So then how to differentiate whether it's a normal thing or?
Yeah, and that's why we look for ancillary findings. We look for transient dilatation of the ventricle. We also get the ejection fraction at rest and at stress. Usually in a significant balanced triple vessel disease, we may get a fall in the stress ejection fraction. And we may get a transient dilatation on stress of the ventricle. So if we find a completely normal looking scan, but there is a fall in the EF on stress and there's a TID, we say that this could be balanced triple vessel.
We also see for the lung uptake.
Yes, lung uptake is another important thing.
Just a comment, sir. It was a lucid presentation by you. And I have been sending two or three patients who were classified as idiopathic ventricular tachycardias. But later on they turned up to be myocardial sarcoidosis. And here the activity of sarcoid, what it is, whether it is the healed stage or it is the active stage, we get a beautiful information by.
Absolutely. Quite right. I didn't put up a slide for that, but inflammatory sarcoidosis, myocarditis, FDG can show very well. We usually combine it with a resting perfusion scan and the FDG PET.
Thank you very much, and give him a round.
Thank you so much, sir, for your knowledgeable session. I request Dr. Pradeep Gupta, sir, HOD Cardiology Department, SEAMS, to present a token of appreciation to Dr. Vikram Lele, sir, Director, Department of Nuclear Medicine, Jaslok Hospital, Mumbai. I request Dr. R.R. Vavre, sir. Dr. R.R. Vavre, sir, Dean SEAMS Medical College, to present a token of appreciation to Dr. Pradeep Gupta, sir, HOD Cardiology Department, Sri Aurobindo Institute of Medical Science, Indore. Thank you, sir. The second session will be conducted on the topic molecular imaging and targeted radionuclide therapies, how they can be changing oncology practice, by Dr. Karuna Luthra, ma'am. She is the Director of Department of Nuclear Medicine at Sir H.N. Reliance Foundation Hospital. The session will be chaired by Dr. Prakash Chittalkar, sir, HOD Medical Oncology, Sri Aurobindo Institute of Medical Science, Indore, and Dr. Manish Bhagat, sir, HOD Radiology, SEAMS. I request the chairperson to take the stage.
After a wonderful exposition on the nuclear medicine aspects of cardiology and some communicable diseases, non-communicable diseases. We have another huge area of non-communicable disease, which is cancer in our country, and which is at least 14 lakh new cancer patients per year in the year 2025. And none other than Dr. Karuna Luthra will present to you the aspects of nuclear medicine, aspects of theranostics. It means the science and art of using the isotopes and the molecules for the treatment of cancer. Dr. Karuna Luthra is alumni of the Calcutta National Medical College, Calcutta, and she is currently the director of the Department of Nuclear Medicine at the Sir H.N. Hospital, Mumbai. And she has extensive experience of over 22 years in the field of nuclear medicine. She has an expertise in cutting-edge imaging technologies, including SPECT-CT and PET-CT, utilizing wide range of radiopharmaceuticals. Dr. Luthra also specializes in the PET-CT imaging of both oncological and non-oncological conditions with advanced imaging like FDG, gallium-68, dotted PSMA PET, fluorodopa brain PET, FAPI PET, which we just heard about, and extending PET. In addition to her excellence in the diagnostic imaging, Dr. Luthra has made remarkable contributions in theranostics, molecular targeted radionuclide therapy, which has revolutionized the cancer management. She has performed over 1,000 targeted therapies in conditions like thyroid cancer, neuroendocrine tumors, advanced prostatic cancer using therapies like high-dose radioiodine, PRRT, PSMA therapy, and targeted alpha therapy. Dr. Karuna Luthra's illustrious career includes her previous roles as Additional Director of the Nuclear Medicine at Jaslok Hospital, Mumbai, a decade-long association with Lilavati Hospital, Mumbai, and her early work at the Tata Memorial Hospital, where she was part of the pioneering team which introduced PET-CT imaging in India in 2004. She is currently the president of the Western chapter of the Society of Nuclear Medicine in India and is actively involved in academic and teaching activities, including being a DNB teacher for nuclear medicine. Dr. Karuna Luthra is deeply committed to providing excellence and diagnostic nuclear medicine and personalized theranostic care with compassion and dedication. Over to you, Dr. Karuna Luthra.
Thank you, sir, for your very kind introduction. I would first of all like to extend my sincere gratitude to Sri Aurobindo Institute of Medical Sciences and particularly Dr. Bhandari for having me over. And more than anything else, as Dr. Lele said, we are totally overwhelmed, and it is really admirable how one person's dream has been brought into reality. And I would like to congratulate each and every faculty member and every doctor and person who is part of this great institute, because you all are, I think, carrying forward the dream which he had envisioned. And we had the opportunity to visit some of the departments, and we were truly impressed by the world-class services being delivered over here. So thank you to all of you. And at this moment when you all are on the journey of embarking upon the introduction of the cyclotron, and very soon you will have a lot of exciting new radio tracers available to you, doing a lot of exciting new work in nuclear medicine. I think we are all envious of you, because perhaps we will also hope that we'll get some of the radiopharmaceuticals from your cyclotron and be able to even do some work in Mumbai. So I think Dr. Lele has already told us about cardiology, neurology. Nuclear medicine has a wide scope. There's a lot of role in endocrinology practice, infection imaging, and various topics, but of course we'll have to keep our scope of today's discussions limited, and I will be talking about nuclear medicine in oncology, the diagnostic as well as the therapeutic aspects. Yes. Can I just put that how? It's working. Okay. All right. So, at the heart of nuclear medicine, At one side, we have the technology. We have two types of scanners, the gamma camera or the SPECT or the SPECT CT. And there is a certain, types of radioisotopes which emit gamma rays, which are used for gamma ray imaging, including technetium, which is the workhorse of nuclear medicine for many, many years. Since 2005, when we got the first PET CT in India, in Mumbai, at the Tata Memorial Hospital, since then, things really began changing, and now a lot of nuclear medicine, I would say about 80% of the imaging work has moved on to PET and PET CT. And we use different tracers here. We use fluorine 18, oxygen, ammonia, which are short-lived isotopes typically, and they provide very high quality imaging because of the positrons. And these positron emitters are typically produced in cyclotrons, and therefore the cyclotron and the PET CT go hand in hand as a pair to allow us this kind of molecular imaging. The importance, again, I would like to emphasize is that in nuclear medicine, apart from the machine, the radiopharmaceutical or the radiochemistry is a very important aspect. It will be interesting for you to know that I think, we have a Society of Nuclear Medicine India, which is associated also with the Society of Nuclear Medicine and Molecular Imaging USA. And I think this is one of the few medical societies which comprises not only physicians, but almost half the members of the S.N.M. India is the technologists and the radiopharmacists, because it is what they develop at the molecular level and how we use it. It is the interaction between both these groups, the physicians as well as the radiopharmacists, the physicists, that we are able to actually deliver the overall molecular imaging for our patients. So, again, big revolution came when we got fusion imaging. From just SPECT, we moved to SPECT CT, and today the PET CT image provides us not only a whole body molecular pattern of the disease which we are studying when we are looking for tumor, but every PET CT scan is also comprises of a whole body diagnostic PET, CT image. Now, one cannot discount the importance of radiology imaging. When we are looking at lungs, we have to look at the CT image. When we are looking at operability of tumors, we have to look at the CT image, the vascularity, the relations with the various organs, and therefore it is this dual modality and the dual information which is provided by fusion imaging of a whole body PET CT that is very critical in oncology imaging as a whole. So, just a basis and a review of molecular imaging and the importance of PET CT. We know that cancers, when normal cells change into cancer cells, they change their metabolism. They start using more glucose, they start using more protein because they need to multiply. The nucleic acid metabolism increases, the tumor cells overexpress certain receptors, vascularity in these areas increases. So all these changes can be very well picked up when we are going to be able to target the specific molecular changes happening in these tumors, and therefore whereas conventional radiology has to depend on the formation of a mass before it can be detected on imaging, there is an earlier detection of tumor formation which can be detected by PET. So the commonest tracer which we have used so far is fluorodeoxyglucose. This is the normal distribution of fluorodeoxyglucose in the body. The brain is the part of the body which uses maximum glucose. There is some amount in the myocardium. We have read how we use this tracer for actually diagnosing diseases of the brain and myocardium. But other than that, apart from some amount which is getting excreted to the kidneys, the normal metabolic pattern does not show any significant glucose metabolism elsewhere in the body. FDG is an analog of glucose. Once it enters the cell, it cannot be metabolized further, gets trapped, and that is how we image it. Now, this is a patient where we are not seeing a normal distribution, we are seeing this abnormal focus of activity, and that, as we all, I think, today know, is where we detect cancer. Cancer cells use increased glucose, and we are therefore able to pick them up when we scan the whole body. So what is the importance? When we are initially diagnosing cancer, it can present to us in various ways. Either we have picked up a lesion clinically, or we have picked up an image on any other imaging like a mammography or a X-ray or a CT scan, and we want to know whether it is a tumor or not. So for further characterization, we use PET-CT. The other indication is that when patients are suspected of having cancer, like patients presenting with unexplained body weight, fevers of unknown origin, paraneoplastic syndromes, and we have to look that where is this little tumor hiding in the body causing these symptoms. That is when we use PET-CT for diagnosis. For staging of disease, the advantage is that PET-CT can allow us at one go picking up of metastasis in every organ. We don't need to do separate studies for different organs, and in one body imaging we get a whole body coverage of the metastatic burden of the disease. And I think most important, apart from other organs, is the picking up of bone metastasis, which is so common in lung cancers, breast cancers, because the changes on radiology typically occur very late, and we would not pick them up on any other imaging unless we do PET. So there are strong recommendations by the NCCN that PET-CT needs to be included in the staging of a large number of tumors, including non-small cell lung cancers, lymphomas, esophageal cancers, head and neck cancers, apart from thyroid, cervical cancers, more than stage 1B, 2, melanomas, colorectal cancers, breast cancers, stage 3 or above, and sometimes in early stage 2Bs, thymic tumors. And PET-CT is also recommended in selective cases for staging of pancreatic cancer, ovarian cancer, sarcomas, testicular cancers, thyroid cancers. At this point, I would also like to add that even though metastatic disease has been picked up by any other imaging modality, you may feel at that point that, we already know it's metastatic, the patient is going to go for systemic therapy, why do we need to do a PET? But here is what happens, that when you don't have a baseline PET and when we want to evaluate response to therapy, that is where we are at a loss, when we don't have a baseline metabolic imaging. Because when we want to do response evaluation and follow-up, as you can see, the morphological changes and the metabolic changes in tumors may not always go hand in hand. This patient initially on treatment had a case of breast cancer with a lot of lymph node disease, large masses in the axillary region. On the follow-up after treatment, the CT scan continues to show these residual masses because masses take time to resolve morphologically. But if you look at the PET imaging, it has become totally metabolically inactive. This is complete metabolic response to therapy, and for this reason, a PET, when we are looking at response evaluation, becomes essential. So while PET-CT FDG has high sensitivity in imaging all these cancers, lymphomas, head and neck, lung, breast, GI tract, and taken up very intensely by all these tumors, there are some tumors which are not very FDG avid. So that was the problem, and that was the requirement, that newer tracers had to be developed and we could not do with FDG alone. So apart from fluorine-18, other radioisotopes were explored, and out of them, the most important, which has been able to tag the various ligands for imaging, has been gallium-68. So here is a list of some of the commonly used. If I go into, talking about the large number of radiotracers we have today, which can potentially image different aspects of tumor function, it is very long. But this is just a list of what we are commonly using today in India. So apart from FDG, we have prostate cancers, which we can image using the prostate-specific membrane antigen, or PSMA PET. For neuroendocrine tumors, we image the somatostatin receptors. We have dotatate PET. For imaging a variety of tumors, for example, breast cancer, apart from FDG, it also it may or may not always overexpress estrogen receptors. So we have fluoroestradiol, which can actually help to see that whether this breast cancer is expressing estrogen receptors or not. So whether estrogen targeted therapy is going to work for the patient or not. So not only whether a tumor is present, whether it is responding or not, we also characterize the various metabolic patterns, the various receptors in the tumor, so that we can target treatments to these tumors in a more informed way. So I'll just introduce some of the common ones. The commonest amongst which has become very popular now is the PSMA PET CT, because prostate cancers overexpress these receptors and more than the normal cells, and this receptor expression is increased even more when these are the castrate resistant prostate cancers, and therefore if we use a ligand which is gallium tagged, that is the a small peptide receptor, we are actually able to image these overexpressed PSMA receptors in prostate cancer. Now this is a patient with an enlarged prostate gland. The PSA level is also very high, but we are not sure whether he is harboring a prostate cancer or not. When we do a PSMA PET, we just find this diffuse, heterogeneous, low-grade uptake in the prostate, and we are sure that this is not prostate cancer. On the other hand, if we find a focus of increased tracer uptake, high PSMA positivity, this is definitely prostate cancer. So when in pathology they use IHCs or immunohistochemistry, they are again looking at these targets, these molecules which they are actually filming or tagging with the different dyes and looking at them under the microscope. It is very much similar to that actually. When we are looking at an overexpression of a molecule over here, we are just actually labeling it with radioisotopes and looking at it under the imaging device, that is the PET scanner. So for the diagnosis of prostate cancer, multiparametric MRI has always been the gold standard, and it provides us the PIRADS grading, and the PIRADS 4 and 5 lesions are the ones which are highly suspicious for tumor detection. But there were some studies done which compared back to back whether a PSMA PET or a multiparametric MRI, which would be the higher sensitivity and specificity. And what was found is that if you're looking at intermediate or high grade prostate cancer detection, then definitely PSMA PET had an edge, and it had a sensitivity of almost 100% in detecting these tumors. Multiparametric MRI also was excellent, 97%. Sometimes small areas may or may not be picked up by them. And the best combination, of course, came when you combined both the modalities. So if you have a PET MRI, that is going to be our strongest tool in detecting these tumors, and that is what. Now when it came to very low grade or the Gleason 6 kind of prostate cancers, both of them, MP-MRI as well as PSMA, did not fare very well. Okay. So when the tumor is diagnosed for the T staging, it is very important today that PSMA PET, it can tell you whether it is the cancer is limited to within the confines of the thyroid, of the prostate gland, or whether it has spread. And therefore, when we do PSMA PET imaging, we will give you a T stage of the tumor, whether seminal vesicles are involved or not, whether, the only area where it does not do as well as MP-MRI is whether neurovascular bundle is involved, and for that reason an MP-MRI always helps when we are looking at only the T. But when it comes to end staging of the disease, for picking up tiny nodes, PSMA PET is highly specific and much more sensitive than any other imaging modality for picking up metastasis in tiny nodes in the pelvis. And of course, for the M staging, disease anywhere in the body, as you can see, very strong expression of this receptor, and we can pick up tiny metastasis spread anywhere in the body. So today, PSMA PET CT has become the standard of care for the initial staging of prostate cancer before you embark upon the treatment, whether a decision is taken to go for surgery or radiotherapy upfront, or we know that the disease has already metastasized. The second category of tumors is the neuroendocrine tumors. I will speak about this kind of tumor because it was considered to be a very rare tumor. And over the last decade or so, we see that there is more and more people being diagnosed with this neuroendocrine tumor. One major reason for this increased detection has actually been ascribed to the IHCs, because they are able to actually categorize the tumors which they are seeing between like a pancreatic cancer, rather than it being labeled as a pancreatic cancer. Today they can very well tell us that no, this is a neuroendocrine tumor. The prognosis, the treatment, everything is very different. In the same way, because of improved imaging, and because now we have these tracers, that is gallium dotatate, to image these tumors, we are picking up many, many more tumors, and therefore the incidence is, so as to say, increasing. Now, neuroendocrine tumors can originate from neuroendocrine cells which are scattered in many organs in the body. Now, they may be consolidated in certain organs like the pituitary, like the thyroid, like the adrenals. And other than that, there are these tiny cells which are spread in our GI tract, in our respiratory tract, where they actually secrete peptides. And these peptides regulate a lot of functions in our body. So therefore, tumors which develop from these neuroendocrine cells, they can present in two ways, because these cells secrete a large number of peptides which have different functions. For example, gastrin, which causes increased production of acid, insulin, which can lead to hypoglycemia, serotonin, VIP, which can cause diarrheas and the carcinoid syndromes, catecholamines, which will cause hypertension, ACTH, which will cause the Cushing syndrome. So therefore, these tumors can either present as various functional abnormalities like a carcinoid syndrome or a Zollinger-Ellison syndrome, or the non-functioning tumors, on the other hand, will remain silent for a long time. And sometimes they present when the disease has already metastasized and the patient actually clinically manifests at a very late stage. The good thing is that neuroendocrine tumors overexpress a receptor on their surface, which is called the somatostatin receptor. There are 5 types of receptors, out of which 2 is the commonest. And today we have ligands, which we label with gallium-68 isotope, and we are able to image these. Earlier there were some technetium and indium labeled isotopes which were not doing as well, but gallium dotatate PET-CT today is almost got a more than 95% sensitivity as well as a specificity in detecting these neuroendocrine tumors. As you can see, neuroendocrine tumors, they are slow growing tumors, and therefore when we image them with FDG, this is the patient on the left side, a PET imaging was done with FDG, and you don't find really that there is much disease except few suspicious areas here in the bones. But the same patient, when we are using receptor targeted imaging with dotatate, you see how much the disease is present, and we can actually pick up where this metastatic disease was originating from. This patient had a tiny primary tumor in the stomach, and this is what it had spread to and causing this level of disease, which was totally almost blind on FDG PET. So this is another patient. He was a 56-year-old male. He had been suffering from intractable diarrhea for many years. Diarrhea, hypotension, he had flushing, skin rashes, and all kinds of antibiotics, a lot of treatment taken, no relief. He had undergone endoscopy also. Now, endoscopy is actually very sensitive, and at the hands of a good doctor, they can pick up very tiny lesions, and now you have endoscopic ultrasounds and various advanced endoscopic techniques which actually help pick up these diseases. But there are some areas like the midgut which are blind to endoscopy and cannot be approached, and there are some certain areas of the intestine which may not be properly seen, and that is where imaging, specifically this targeted imaging, comes in handy. Now, this patient had a tiny lesion which was sitting behind his pyloric sphincter, which was not kind of visible on the endoscopy, and for many years he suffered until he had a dotatate PET. This tiny tumor which was overexpressing somatostatin receptors was picked up. The patient underwent surgery for this, and 15 years of suffering because of diarrhea was relieved immediately after removal of this tiny tumor because it was a secretory tumor in his body. So also this patient suffering from hyperacidity. So many patients are just labeled as acidity. They kind of keep taking treatments over the years, but today we have blood tests, we have chromogranin A, we have gastrin evaluation, and once anything like that indicates that this patient may be a person who is harboring a NET, straight away now, they are sent for a PET CT, and in this case we found this tiny tumor in the duodenum, very tiny, which was causing this havoc by producing gastrin. So the other thing you will notice about neuroendocrine tumors is that the primary tumor may be very small, and even though they are very small, they may be secretory, causing havoc. And second thing is that in this case, as you see, that the primary tumor was so tiny, but it had already spread, and the metastases are usually larger than the primary tumor. So this is a very odd thing about neuroendocrine tumors, where the mets are always large, the tumor primarily may be very small. Again, an example of a patient with hypertension uncontrolled, and when he was imaged, a 29-year-old male, detected with multiple paragangliomas. You should know that for detection of paragangliomas, gallium dotatate PET has got almost 100% sensitivity. For pheochromocytoma detection also, it is very good, except in very tiny pheos, where sometimes the background physiological adrenal activity can interfere with detection of the very tiny lesions. Otherwise, for paraganglioma or the extraadrenal ones, this is an excellent imaging modality. So compared to conventional imaging, when it comes to staging of a neuroendocrine tumor, by far gallium dotatate has shown superiority, and it showed that when you want to stage these disease, if you do not do the scan, in up to about 68% cases, you may actually miss making a change in your the actual management. And a lot of series, they showed that 40 to 68% of patients, when they underwent a gallium dotatate PET, it resulted in a total change in the management plan for the patient over and above conventional imaging. That is why the importance today of this imaging modality. Now third, I'll just touch upon a variety of tumors, as I said, which we are using, imaging agents which we are using commonly. There is a condition known as hyperinsulinemic hypoglycemia. These patients, they present with hypoglycemic spells, and you have to check the insulin levels, you have to check the C-peptide level at the time of hypoglycemia. To when it is inappropriately high or normal, insulinoma is suspected. And then insulinoma again is a very small tumor, very difficult to pick up by CT, very difficult to pick up by MRI. Sometimes they are present in the tail of the pancreas. That's why even on endoscopic ultrasound, it may be very difficult to localize these tumors, and that is where this targeted imaging with this tracer known as gallium exendin comes in. So there is a overexpression of glucagon-like peptide or the GLP-1 receptor on insulinomas, and gallium exendin is a small peptide which we use to image this receptor. In this case, as you can see, very bright uptake in the tail of pancreas in a case of an insulinoma. For insulinoma imaging, we also have another tracer, which is fluorodopa. Now, fluorodopa is taken up by the L-amino acids, and it is an analog of dopa, that is a normal peptide or a neurotransmitter, which is present not only in the central nervous system in the dopaminergic neurons, as Dr. Lele spoke about, in the for the imaging of Parkinson's, we use F-dopa imaging, but peripherally also there are certain cells, or the amine precursor uptake and decarboxylation cells, what they were known as earlier, or a certain category of neuroendocrine tumors which actually overexpress these dopa receptors, and we can use fluorodopa to image these tumors, commonly used in imaging of insulinomas other than exendin, and for imaging of tiny pheochromocytomas. It can also have an advantage of imaging certain NETs over and above gallium dotatate, including medullary CA thyroid and some of the mid-gut carcinoids. This again, just fluorodopa imaging of the brain. Now, when it comes to imaging of primary brain tumors or gliomas, this is the normal pattern, high uptake of FDG in the brain, and therefore when we want to look for a hotspot for detection of a tumor or detection of tumor recurrence, it becomes very difficult, and FDG PET is not an ideal modality for detecting gliomas. So we needed another molecule. So we have two categories of molecules which we use for brain PET tumor imaging. The first is the nucleic acid molecules, out of them being fluorothymidine, because these cells are proliferating, there is a higher turnover of nucleic acids in these tumors, and therefore there is higher uptake of this fluorothymidine. Now, fluorothymidine again is a tracer which can be very easily produced in a cyclotron. This is a patient who has been treated, operated, as well as given radiation for a brain tumor. On a follow-up scan, MRI, sometimes it becomes very difficult to differentiate between radiation necrosis versus tumor recurrence. FDG PET, again, not really adding much value. But when we did a fluorothymidine PET, there is intense uptake in this region, and we are very sure that this is not radiation necrosis, but it is viable recurrent tumor. Interestingly, fluorothymidine is also used other than brain imaging for imaging, sometimes, for lung cancers. When you have tumors, you have a lot of infection in the lungs. In India, there is a lot of tuberculosis, and sometimes the nodes, it may be difficult to differentiate whether the nodes are because of nodal metastasis or whether it is some infection going on. So there again, fluorothymidine can help us differentiate, because it will go only to tumor, it will not go to infection. So that is another utility of this radioisotope. And brain tumor imaging, we also use the peptide imaging agents like carbon-11 methionine, fluorodopa, fluoroethyl tyrosine, which again have the same effects like fluorothymidine and help to differentiate radiation necrosis versus tumor. Another receptor category is the chemokine receptor 4. Chemokine receptor 4 is overexpressed in a lot of hematological and lymphoid malignancies, and most important among them, for example, lymphoma is very well imaged with FDG itself, so we don't really need another tracer. But there was one of the hematological malignancies, that is myeloma, multiple myeloma, which is not very avid on FDG PET. As you can see in this patient, you don't really see much. But when you image the same patient with the chemokine receptor 4 or the pentixer 4 PET, you see that you can actually visualize the extent of disease. So, more and more as we are practicing, more and more as we are getting newer tracers, we are able to kind of distinguish and decide that for which particular tumor category what tracer needs to be used, and then we are sort of shifting our imaging away from plain fluorodeoxyglucose towards these tracers. Chemokine, the pentixer 4 PET is also interestingly used for imaging of adrenal adenomas. Adrenal adenoma is a very common incidentaloma which is picked up in patients during CT scans or due to any other imaging. But whether it is a functioning adenoma or just a quiescent adenoma, for whether it is an aldosterone producing or a cortisol producing adenomas, endocrinologists today send patients to us for gallium pentixer 4 imaging to distinguish between a non-functioning versus a functioning adenoma. Lastly, I think there's one more tracer. We have a whole array of tracers. This is gallium FAPI PET, which we are using a lot nowadays. It is the new multi-purpose tumor imaging agent, because as we know that when a tumor forms, when a tumor mass forms, especially when these solid tumors form, apart from the tumor cells, there are a lot of there's a lot of stroma present in the tumor, and in the stroma of the tumor, there is overexpression of cancer-associated fibroblasts, because these cancer-associated fibroblasts actually help to increase the vascularity of the tumors. They help the tumor to actually spread into the surrounding organs, and these CAFs can be, they overexpress a peptide known as the fibroblast activating protein. This fibroblast activating protein is imaged by the gallium FAPI, and this was a paper which was published in the Journal of Nuclear Medicine a few years back, and it opened up the gates for us to use this as a tracer for imaging a variety of cancers with a very high degree of sensitivity. And it had a certain advantages over FDG PET. For example, in this tumors which I mentioned, which do not pick up FDG very avidly, included amongst them being the signet cell cancers of the stomach, signet cell cancers of the colon, lobular type of breast cancers, ovarian cancers, pancreatic cancers, hepatocellular cancers, cholangiocarcinomas, and some advantages in head and neck cancer imaging, where FDG may not actually pick up the disease. When we image with gallium FAPI, you can see the the intensity and the high sensitivity and specificity for tumor pickup. There is another agent on the block now, gallium trivexin PET. Again, it is an imaging modality for this receptor, the integrin receptors, which are overexpressed on epithelial tumors. And it has an advantage in certain situations. In head and neck cancer and pancreatic particularly, it has been used. And this tumor imaging agent is now also proving to be very useful in imaging parathyroid adenomas because these are again small tumors. They need high sensitivity imaging, and trivexin PET is now the first almost go-to now when we are looking for a parathyroid adenoma also. Some tumors can express multiple receptor types. For example, pheochromos, they can overexpress MIBG. This was a traditional scan which was done earlier, dotatate, F-DOPA. So it is the duty of the nuclear medicine physician to actually judicially use how, we are going to select which tumor imaging agent we are going to use for a particular patient. Now moving on to the topic of using these molecular targets, which we have now been able to identify using these array of tracers to translate them into delivering targeted radiation to these various tumors. Okay, so when we know cancer treatment, it involves a lot of there's going to be a surgeon involved, the medical oncologist has a very important part to play. Amongst all these treatment modalities, one which has already proven its importance is radiation therapy, and we know that radiation kills tumors. So conventional radiotherapy has been delivered using these external devices, and where we try to target this external beam of rays onto a tumor mass anywhere in the body, so that we can kill those tumor cells with a very good effect. And nowadays stereotactic techniques, image guided radiotherapy, and lot of other types of, the main aim has been that radiation has to be delivered to the tumor, and yet it must not cause damage to the surrounding structures. So while it is possible in a lot of areas like the spine, like the bone or the peripheral areas, some areas like the chest or those which are close to very vital organs, delivery of external beam radiation becomes difficult. And therefore, proton beam has evolved. In proton beam also, they try and target a very high dose of radiation to a very specific tumor area, but all the efforts are basically towards delivering targeted radiation and sparing the non-target areas. So here is where molecular targeted radiation comes in, because here we are literally able to deliver these radioisotopes directly onto the cell and specifically onto the cell, because when we know a cancer cell is overexpressing a particular type of a receptor or a particular type of an antigen, we will choose the suitable matched antibody or the suitable matched radioligand, and we will tag it with a small bundle of radioactivity in the form of beta emitting particles or alpha emitting particles. So this acts very much like a courier when we inject it into the body, and it will carry this little bundle of radiation carrying particle, the beta particle or the alpha particle, directly onto the tumor cell. Most of these antibody antigen reactions or the receptor and the ligand reactions are such that they get internalized into the cell, and that tiny particle is reached very close to the nucleus of the cell, where it can actually go and cause damage to the nuclear DNA. So this is actually delivering not only very specific radiation directly to the cell, secondly, we are very sure that it is not reaching the wrong place, and it is a very specific and centered and pointed delivery system, much like a magic bullet, as you may call, where we are directly delivering the tumor cell. So how do we, so this is the basic, the term theranostics is going to come up a lot in the coming years. So this is just an explanation of the term. Theranostics means that we treat what we can image. So once we have chosen the ligand, when I want to check whether there is an overexpression of a particular type of a receptor in that particular tumor, I will do a diagnostic PET-CT by tagging a particular ligand with a positron emitter or a gamma emitter and doing a diagnostic imaging. And there, where I find that yes, this tumor is overexpressing this receptor, then I will tag that same ligand with a beta or an alpha emitter and proceed to do targeted radiation. So first we image, then we treat. The difference between the two types of radiation, the beta particles and the alpha particles, is that beta particles, they carry a good amount of radiation, but they are lighter particles. They can travel in tissue over a matter of a few millimeters, and therefore they deliver this radiation over few millimeters. It is targeted enough, but still, you know, just a little overhang, and sometimes this little bit of an overshoot is good for us because it helps, you know, there's a cross radiation happening to the surrounding cells also. Alpha particles, on the other hand, they are heavier particles, but they carry much, much higher strength of radiation. So they travel for very short distances, only micron distances within the tumor. So when we are looking at very tiny tumors, metastatic all over the body, we may want to choose a alpha agent when the size of the tumors is not very large, and yet be able to deliver high packets of radiation to these tumors. The amount of radiation delivered by a alpha particle is almost 100 times more than a beta particle. So whereas beta particles, including iodine 131, lutetium 177, yttrium 90, samarium, phosphorus, strontium, they cause single strand DNA breaks. The alpha particles like radium 223, actinium 225, they deliver double strand DNA breaks which are not repairable, and therefore much, much more effective in causing a tumoricidal effect. The other advantage of this targeted molecular radiation, of course, is that whereas external beam can be targeted only to limited areas in the body, but when we are dealing with this kind of disease and we want to target radiation to so many areas, we can reach it just by one injection which is given intravenously, and by molecular targeting it can reach innumerable sites in the body. Okay. So again, some examples of theranostics. We use it actually in two ways. For example, the oldest form of theranostics which we have been practicing in nuclear medicine has been the radioiodine treatment, which we give for thyroid cancers. In that, we use a simple principle that we first give a small dose, a test dose of iodine 131, and we image how much is the residual, and then if it is present, we give a high dose of iodine and ablate that same tumor. So also for I-131 MIBG for neuroblastomas, pheochromocytomas, where it is a principle of small dose, high dose. But with these newer peptides and with the pairing of the imaging and the therapeutic theranostic pairs, we use one common ligand, but we use different isotopes, positron emitters for the imaging and the beta emitters for the therapy. So thyroid cancer, after surgery, there may be little beds of thyroid tissue which are remnant in the neck. With the best efforts of the surgeon also, some thyroid tissues which are congenital remnants may sometimes remain in the neck, and these remnants will not allow the thyroglobulin, which is the tumor marker for thyroid cancer, to go down to a subnormal level. or an undetectable level, and therefore they do not allow us, if they are present in the neck, to be able to follow up these patients by using a simple blood test, which is thyroglobulin. Therefore, it is important, number one, even if there is no gross evidence of metastasis, you may want to ablate whatever residual tissue is present in the thyroid bed after thyroidectomy by giving a radioactive dose. Of course, if there is metastatic disease present in the body, for example, this patient who had a lot of lung metastasis, we will give a high dose of iodine. We can give it once, we can give it twice. And because of this high radiation which is delivered to these tumors, for many years we have studied that, you know, thyroid cancer, even though it is metastatic, it behaves very well. That is because radioiodine has been such a powerful tool for treatment of this cancer. And secondly, it has shown a very good track record in spite of delivering large doses of this radiation to the tumor, because it has got such a targeted localization and very low uptake in the non-target areas. It has shown an excellent safety profile for decades without causing any other major side effects or any other secondary tumors. So, PRRT, or the peptide receptor radioligand therapy for neuroendocrine tumors, this allows us to treat these tumors. Instead of imaging with gallium dotatate, we will label the dotatate with lutetium-177 or yttrium-90 or actinium-225 and deliver targeted radiation to these metastatic tumors. It is given in an intravenous form, and the patient is admitted. We give some hydration, we give some protein infusions in order to block the non-target uptake in the kidneys, and thereafter we infuse the patient over a period of about 15 minutes with this lutetium dotatate isotope. After that, we take an image which is known as the post-therapy scan, and we see that yes, whether what we have injected has properly localized in the tumors or not. Now, these cycles of therapy are given at every 8 to 10 week intervals, and at every cycle when we take the post-therapy scan or the lutetium post-therapy scan, we are able to actually image how the patient is doing, whether the disease is responding or not. So, this is a gamma camera imaging which is done in the post-therapy situation. So, typically 4 cycles are good, and you see good responses in tumors, and PRRT has shown a response in gastrointestinal tumors. It shows that at least about 20 to 25% will show a significant partial response. About 30% of them may show a mild response. About 25 to 30% will show stabilization of disease, and about 5 to 10% will show disease progression in spite of PRRT. But because these are slow growing tumors, and as long as we attain disease stabilization, arrest the tumor from progressing, that is also considered as an optimal response, and that has been now demonstrated in various tumors. The NETTER trial had shown the superiority of giving lutetium dotatate therapy along with long-acting sandostatin or long-acting octreotide analogues over the octreotide analogues itself, and that kind of triggered the acceptance of lutetium PRRT by the European Medical Union. And this is actually one of the areas, PRRT for neuroendocrine tumors, where Europe, where India and Australia has been much ahead of the USA, because in USA the approval for PRRT came much later, only as recently as 2024. Whereas in India, we have been very fortunate that our own agencies, the Bhabha Atomic Research Center, has been providing us lutetium-177 dotatate from as early as 2014-15 for patient use, and therefore this is one area where India has large experience. Centers like Radiation Medicine Center, which is associated with Tata Memorial Hospital, they have treated thousands of patients with very good results with lutetium PRRT. Today it has entered the management algorithm for mid-gut NETs, for pancreatic NETs, for lung and thymic carcinoids also. It has demonstrated again a very good safety profile. We use it for metastatic tumors. We use it for also inoperable neuroendocrine tumors, and now the PRRT is being also used in the neoadjuvant setting. If you have a tumor which is currently inoperable, you may actually want to downstage it by giving a few cycles of PRRT, and therefore in this case it was a pancreatic mass, initially inoperable, but after 4 cycles it almost went away, and thereafter when the surgeon went and he was able to kind of get it out, there was very small tumor residual present. So this is the expanding role of PRRT. So it is not something which we give as a palliative condition. We are using it much earlier in the disease process also. And the third reason why we use PRRT is for functioning NETs. This was a patient with intractable diarrhea, a small mid-gut NET, extensively metastatic to the liver. After giving 4 cycles, we found that the size of the liver has regressed significantly, so the overall volume of disease has reduced. It's not that it has gone away, it is still there. There's still a large disease burden, but the good thing is after 2 cycles of therapy itself, his diarrhea totally vanished, something which he had been suffering for, and a patient which has this disease burden, it can be a horrible life for them, suffering from this kind of a diarrhea. So for control of symptoms also, it is very, very effective when we use PRRT. Again, an example of a young boy with hypertension, poorly controlled with 4-5 categories of drugs. The tumor control may not happen, but PRRT definitely helps in actually suppressing the disease activity or the secretory activities, and this patient he had tremendous response to his hypertension even after the first cycle. Again, this is a little deep into the subject. Sometimes you have to use both SSTR and FDG PET CT imaging to characterize the tumor, how fast it is metabolically active, and based on that we sometimes use combination therapies where we use PRRT along with chemotherapy, like the CAPTEM regimen along with PRRT for managing a little higher grade disease. NETA-2 trial was out last year, and it showed us that even for higher grade neuroendocrine tumors of the grade 2 and 3, now there is a role for upfront PRRT. Similar to PRRT for neuroendocrine tumors, we use PSMA targeted therapy for prostate cancer, overexpression of the PSMA receptors, and we will tag it with lutetium-177 or actinium-225 PSMA to deliver radiation. So after the initial treatment with surgery or with radiation of the prostate gland, when the disease recurs, supposing at a stage of recurrence we find that there is disease only in up to 3 sites, whether it is lymph node or whether it is bone metastasis, these up to 3 sites is considered as oligometastatic disease, and it can be treated with external beam radiation and it can be dealt with. But if we find in the metastatic stage that there is extensive disease, that is the stage where we bring in lutetium PSMA targeted therapy or actinium PSMA. Again, it is given intravenously like the PRRT. Over here, the cycles are given at shorter intervals because prostate cancer in general is a more aggressive disease than a neuroendocrine tumor. So here we will give the cycles at about 6 weeks intervals, sometimes 8 weeks. An example of a case with extensive metastatic disease received 3 cycles, and the post-therapy lutetium scans showing progressive reduction in the disease burden. Very good for soft tissue metastasis also, in this case an example with lymph nodal metastasis responding very well. This is just to show you an example of a patient who was given actinium-225. Earlier I spoke about that how alpha particles are much more stronger than the beta particles. So what it takes usually 3 or 4 cycles for beta to act, and actinium sometimes can do it just in one shot, as we saw in this very fortunate patient, where with one shot his PSA, which was more than 400, reduced to almost 1.86, and his disease burden showed tremendous reduction. Again, prostate cancer patients are older patients. They are not very fit after they complete their hormonal therapies. They are usually not fit enough to tolerate chemotherapies like docetaxel, and that was the situation with this person who was 91-year-old with this level of metastatic disease. In spite of his age, we were able to deliver 3 cycles of lutetium PSMA therapy without any significant side effects, causing a significant biochemical as well as imaging response in this patient with a very good safety profile. Again, lot of trials, the therapy trial to begin with, and thereafter the vision trial, which was recently a result of the FDA approval of lutetium PSMA therapy for prostate cancers. They have all demonstrated the benefit. The therapy trial demonstrated benefit of the lutetium PSMA therapy over cabazitaxel in progression-free survival of these patients. The vision trial, after even patients who had received docetaxel, when they were kind of split into groups which received lutetium PSMA versus standard of care, lutetium PSMA showed significant improvement in the quality of life as well as good improvement in the survival. Now the move has been to actually, there are trials which are the PSMA-4 trial and the PSMA addition trial, which are now realizing that we need to bring this therapy much earlier in the disease regime, and we don't have to wait till the palliative state. The time when the patient stops responding to hormonal therapy, probably that is the good time when one has to decide, and these therapies are actually going to come to the fore before chemotherapeutic agents like docetaxel. FAPI therapy is also being tried in a number of cancers, very initial stage in India today. We don't have as much of experience or any large trials as we have with PRRT for NETs or for prostate, but a lot of initial trials are being made for treating tumors which are not treatable by other reasons. For example, iodine refractory thyroid cancers, aggressive advanced breast cancers not responding to other therapies. So lutetium FAPI is being tried in a variety of cancers, whether it can alone or in conjunction with chemotherapy help get some disease response. Examples, MIBG therapy of course remains. We have been using it for many years. MIBG therapy for treating metastatic neuroblastomas and metastatic or inoperable pheochromocytomas, and being an I-131 targeted agent, of course it is very strong, and lesser number of doses, 2 or 3 sometimes, can cause significant responses in these tumors. A small niche area where we use radioisotopes is for bone pain palliation, where radium-223 has shown significant results in prostate cancer, breast cancer patients also, and we have tracers, isotopes like samarium, strontium, which can be used to treat bone pain. So to summarize, in nuclear medicine, theranostics combines diagnostic imaging and therapy with the same but differently radio-labeled molecule in different dosages. Targeted beta and alpha radionucleotides are very effective ways of delivering lethal doses of radiation to tumors. And since they spare the non-tumor or the non-target areas, these therapies have a very good safety profile as compared to other therapies. And combination therapies of targeted radiation along with chemotherapies are now being used to deliver personalized medicine treatment to a lot of cancer patients. With more and more availability of newer isotopes and hopefully newer tracers which are going to come out of the cyclotrons in the near future, nuclear medicine has a very wide scope in entering the field of therapeutics in oncology. With that, I would like to thank you very much for your attention.
Thank you, Dr. Luthra, for exhaustive and of the cancer treatments with radioisotopes. I have one quick question before I throw it to the house. Artificial intelligence, algorithms are everywhere. Neuroradiologists are saying we can tell you whether it is a IDH mutant glioma or not. Has the nuclear medicine specialist also found AI algorithms to improve the diagnostic abilities?
AI algorithms are definitely useful and. Huh? Then you were saying something? No, say. Yeah, so not only in the diagnostics, when we are evaluating response to therapies, a lot of algorithms are actually helping us to determine change in metabolic tumor volume, which is sometimes an important information for the, the medical oncologist. And various algorithms we are actually now seeing being developed to sort of help us not only in our reporting and delineating, because you see PET imaging, we are imaging the entire body, we are looking at multiple scans. So AI algorithms are definitely helping us, and so that we don't miss any lesions, so that we are able to actually determine the minute changes in these tumor volumes and the SUV parameters.
As a cancer clinician, what we face is the problem of resolution 1, often enough. And so I was wondering whether you're using those algorithms in order to come to conclusions.
See, AI in some form we have been using for years. Like when we use cardiology imaging, we have these polar maps and we have a database, and there is this correlation when we use brain imaging also. So in some shape and form, AI has been used for a long time, but now more and more algorithms are being developed by our instrument suppliers, as well as a lot of third-party software, which are going to help us in better elucidating these
Thank
changes.
you. Questions from the floor? Mic.
So as of now, we have, if you're talking about trials, we have a trial which definitely can show that post-docetaxel, definitely it has an advantage of going for lutetium dotatate versus going to the cabazitaxel arm. But smaller studies, and there is an ongoing very important study, which is the PSMA4 study, where they are actually studying, and they have got the two randomization between lutetium PSMA versus docetaxel or chemotherapy, and the result of that is still awaited, but the whatever initial indications we are getting is that definitely PRRT is PSMA therapy is showing an advantage. See, basically you have to understand the biology of prostate cancer. It is one of those cancers which is not very FDG avid. That is because it is a slow growing tumor, and till a very long stage, even when it becomes initially castrate resistant, FDG PET is typically negative in these tumors, and the PSMA is positive. So you can target it by giving PSMA therapy. But on the other hand, if you're using chemotherapeutic agents which have an anti-mitotic effect, they are not going to act as effectively, because the mitotic activity of this
Is low.
tumor is only low. On the other hand, as the disease gets more and more de-differentiated, as it progresses more and more, when we look at our imaging, we see that suddenly these tumors show lesser and lesser PSMA expression. They become more and more positive on FDG PET. Probably that is the time when we need to bring in the chemotherapeutic agents. So just the sequencing is going to change, I think, in the coming years, and I think a targeted radiation will come in earlier than actually chemo. No. See, initially, typically when a patient comes to us, we do a baseline imaging with PSMA, and we also like to do a baseline correlative imaging with FDG, because we just want to know that even at that point, whether there are some lesions within him which have not already de-differentiated, lost their PSMA expression, become FDG positive. And lot of these trials also, including the therapy trials, used both these imaging modalities to actually select their patients. So only those which are PSMA positive and FDG negative, they are the ones who will do the best with lutetium PSMA therapy. So, see, we have to understand that PSMA, prostate cancer, once it becomes castrate resistant, it is pretty much not going to be totally, treatable. So we are going to choose our therapies based on how we are going to be able to, number one, control the disease, number two, give this patient the best quality of life, because these are all elderly patients. So balancing all these factors, we have to plan our therapies, sequence them in some ways, that we give the PSMA. If we find that there has been a sufficient response after, say, 3 cycles, patient is asymptomatic, we can actually give him a break, follow him up. Sometimes these patients do well for almost up to 6 to 10, 12 months. When they present with disease again, we've again given them 2-3 cycles. Beyond that, typically, the disease will change its character, it will sort of de-differentiate, and then the downfall is sort of.
Thank you, Dr. Luthra. Let's give us a big hand.
Thank you.
Thank you so much, ma'am, for the enlightening session. I request Dr. Prakash Chitalkar sir, HOD Medical Oncology SEAMS, to present a token of appreciation to Dr. Karuna Luthra ma'am, Director, Department of Nuclear Medicine, Sir H.N. Reliance Foundation Hospital, Mumbai. Thank you, ma'am. Thank you, sir. I request Dr. Manoj Kila, sir, HOD Surgery Department, SEAMS, to present a token of appreciation to Dr. Prakash Chitalkar, sir, HOD Medical Oncology, SEAMS. Also request, sir, to please request Manoj sir to kindly present a token of appreciation to Dr. Manish Bhagat sir, HOD Radiology, SEAMS Department. Thank you, sir. Our next speaker for the day is Dr. Anil Kumar Mishra, sir, former Director, INMAS DRDO, Professor, Department of Chemistry, IIT Roorkee, on the topic Emerging Radiopharmaceutics, 18F, 13N, G8GA, and Novel Tracers. The session will be chaired by Dr. Piyush Trivedi, sir, former Vice Chancellor, RGPV Bhopal, and Dr. Priyusha Bagdare, Associate Professor, Medical Physics, SEAMS. I request, sir, for the session.
Good afternoon, everybody, and congratulations to Dr. Bhandari and his entire team. So he has brought in such a short time everything into reality. It's an opportunity to give me introduction to Dr. Mishra, who is a very close friend of mine, and we are from the same domain in the chemistry. He has a specialization in the radiopharmaceuticals, radiochemistry, imaging, medicinal chemistry, pharmaceutical chemistry, and served as director ENMAS, and as well as now he is the professor of chemistry in the IIT Roorkee. I am told that not to introduce much about him because the time is short and he would like to deliver more. So I welcome him here.
Good evening to everyone. Thank you very much, sir, for kind introduction. I know that time is running and many people, they have to leave because I'm really lucky and very honored to be associated with SAMS, Arvindo, and BRM, and fortunate to realize the dream of Professor Bhandari, Manjushri, and Vice Chancellor Madam, and the colleagues over SAMS and BRM that we are going to work with the family. What we want to do is that how we can combine science and innovation through technology to see that we can cure the disease of human origin. Since 2-3 lectures that we have heard about that you can see the potential of this radiopharmaceutical, that you can diagnose and you can treat it. But behind that, there are many things has to be done. And we chemists, we try to play, and it can be played together. Like, you know, that we are talking about the hope of today and realization of tomorrow. Is the same way that we are talking about the medicine of tomorrow. And that's why it's very essential for us to know that what we are going to develop and is for what we are going to develop is very, very important to us. So coming from Institute of Technology, Roorkee, my lab is called Bioinorganic and Radiochemistry, is BIRDS lab, where we try to realize chemistry in a different way, and that can be translated for the clinical application. I'm really grateful that Professor Lele and Karuna, they came here to deliver the talk in a very short time. Somehow Rangarajan, he could not make it. Bala and Sachin, they are really pillar to see that how we are going to develop many things together. So very briefly, I will talk about fluorine, nitrogen, that we are talking about N13, and then why we have to move from this to gallium. There is a genesis behind that. We want to change it from fluorine to nitrogen to carbon to moving to the metallic isotope. There is a genesis behind that. What we try to do is that at SEMS and BRM that we have been talking, that we really like to develop this methodology over here, because then the methodology can be get translated to the clinical application, and you can see the impact in IPR, educational growth, societal mission, and all this is clubbed together. And this is what we are thinking at SEMS and BRM, that to work together to see that. Very quickly, I will just run through all this, that what we have been doing is that you can see this DOPA scan that we did first time in the country way back, very long time. Is not moving here. Is something wrong here? Now it is moving. So you can see that we have got the cyclotron, where we'll be accelerating mostly that proton to produce the isotope that you can see in the my extreme right panel. We have got the liquid gas target in this cyclotron that we are going to have at VRM, that is going to be the SEMS and VRM together to work together. But we have also the plan to have the future for the solid target tree. And it means that any isotope that exists in the periodic table, we can make it very nicely, and that we can harbor it, we can utilize it, we can develop the drugs for the clinical application. Very quickly that I will take you that, since you have heard 2-3 lectures, very nicely that we want to really visualize all the signaling pathway. And the signaling pathway, to do that, we are working with the fluorine-based isotope. You can see that many isotopes that already I have listed here that will be produced at SEMS and BRM. This is the beauty of this cyclotron that we have been talking. To visualize the diseases of different origin, either different type of receptor, either any manifestation anywhere taking, that will be able to visualize it with the fluorine-based isotope, either fluorine-based tracer that we have been talking about. Besides that, if you look at this one, that we'll be doing a lot of computational work to write the sequence, how synthesis has to be done. It means that involvement of Aurobindo University, Technological University, pharmacy, and everything will have to work together to realize this sequence, to make this tracer that can be really injected to the patient to see that what type of manifestation is taking place. Just simply to let you know how we do the chemistry, that whatever we have been talking is a very simple way. We try to see that where we can introduce the electron withdrawing group, where we can introduce the leaving group, where we can introduce the nucleophilic reaction, where we can introduce the electrophilic reaction. I will not go in detail, but you can imagine by this cyclotron that we are going to have at VRM and SEMS, we can produce all the tracer that exist in the world, existed, either we are going to have the newer tracer, we have the possibility with this cyclotron. This is the beauty of this cyclotron that we have got. You can imagine, we have talked about only 3 or 4 type of PET tracer, but you can produce at least 20 to 30 types of PET tracer, depends on the type of receptor that you want to map, the type of imaging that you want to do is organ specific, receptor specific. Either you can talk about any physiological molecule, either in nucleotides, either lipid, either amino acid. All these physiological molecules can be mapped very nicely. This is the one example that the Bikram was also talking about, and then Karunasi talked about fluoroethoxytyrosine. Very simply we can prepare it. Fluoroethoxytyrosine is very easy to prepare it because we have all this tracer that comes with the precursor, and then finally doing couple of reaction, we can really purify and we can give it to our clinical friends to really do the imaging. A lot of innovation we'll be doing because this cyclotron that we are going to have at SAMS or VRM that we have been talking is not only to do the classical work that everybody does. We'll be doing a lot of innovation because we want to have our own IPR, because we have to transfer the technology. We have to really see that how we can develop something that comes out from the Indore city, and it is sold, either its technology is transferred, because the IPR that we are going to have is going to have on the name of SAMS and VRM. So this is, you can see that it's just simple example that I wanted to let all of you know, to know that how much do we inject to a patient. If you look at the calculation here is, I have talked about the 50 gigabecquerel. That is we talk about the radioactivity. And if you do a calculation, it comes in the almost pico nanogram, even below to the nanogram, certain extent it comes to the nanogram. When you talk about 10 millicurie, that we talks about 40 megabecquerel that we have been injecting. You see that what we inject, almost 1.14 nanogram. If you calculate in the terms of the deoxyglucose that we load with isotope, you just look at that 1 teaspoon, that it corresponds to the 3 gram, and 1 grain of sugar is correspond to 4 milligram, 0.4 milligram, almost you can see the 40 microgram, and then after that we do the injection 1 grain divided by 340,000 times. So imagine the quantity we inject to visualize this type of images that we have been talking. This is the beauty of nuclear medicine. This is the beauty of tracer technology that we develop, and then we are able to visualize it. The second chapter that we want to really discuss on the N13 that will be produced specifically at this cyclotron. And in this cyclotron, not only to produce this one, you can imagine any type of disease that you want to see, we will be able to level it. And by leveling, then certainly we are talking about taking this one, anyone is coming from the field of pharmacy, either is coming in the field of biochemistry, either physiology. You can imagine that what type of molecules you can design. That is the case where we are going to open the research and development, where you can design amide, amino acid, derivatives of many, many molecules that can be used for the clinical application. Like you can see that you can do the reaction very nicely with ammonia. You can make the amide, you can make the carbamate. You can imagine the type of drugs that you want to develop very quickly. Like in cardiac imaging, like Professor Bikram Lele was talking about, that we talk about the MIB, we talk about tetraphosphine, we talk about the fluoropyrrole, the compound that we have been talking, we're talking about rubidium, thallium, but certainly we'll be giving our, making this molecule quite often at our center to do the perfusion imaging. Go to the next slide, that why we have to move from the fluorine to gallium. There is a reason behind. Because if I want to really do the therapeutic application, to do the halogenation chemistry with alpha nuclide, either some of the nuclide that matches the fluorine, that comes under the category of astatine 211, very difficult chemistry. And we don't want to realize this type of chemistry in the setup where we have the clinical setup. We would like to have something which is very easy, mixed, purify, and you inject it with good quality control. And that's why we had to move from these to metallic system. And in this metallic system, you can really see that how many isotopes that we have got, we can level in a different way to do the chemistry. You can imagine about, you can do nanomaterials, aptamer, antibody, peptide, amino acid, small molecule, you think about, and you can level it. And then accordingly, you can use for the any physiological or biochemical changes that we have been talking. Very quickly, I will talk about that, why we want to move from the fluorine to the metal ion, like we have the copper, zirconium, and gallium. And gallium specifically because you have seen the data very recently that my previous speaker Karuna, she showed you that how beautifully you can image and then you can extrapolate with the similar type of metal ions. It means that you can use the therapeutic radionuclides for the application that we wish to do that. You can imagine that we have got many type of biomolecules. You can have the monoclonal antibody, you can have the single domain antibody, you can have the bispecific T-cell engager. All these biological molecules that you have been using for immunotherapy very nicely can be modified and can be loaded with this isotope for therapeutic application. So you can imagine that we can have many types of molecule developing in this center for doing the radioimmunotherapy, either PRRTT that was talked about, and then you can really do any type of modification that you want to do with the biological system. And that's why we do a kind of system that we have got at our center to produce the gallium with the liquid target, doing all this sequence that we will be writing, doing the purification, and after purification you have to really load it. So the beauty in this one is that we talk about these metal ions directly you cannot incorporate with the biological system. So you have to design some chelating system, and this chelatic system can be conjugated to the biological molecule. And you can see that designing these chelators being used for PRRTT, either you are being used for radioimmunotherapy, and this ligand was designed by me in 1986, and it's called Mishra peptide method to develop this chelator to load any type of metal ion for diagnostic or therapeutic application. With this, you can imagine that we are talking about fluorine-based compound. The similar way you can do the gallium, you can imagine that any type of cancer that you want, any type of biological molecule that you want, you can label and you can visualize it. And that's why we are talking about advantage and disadvantage of doing the radioimmunotherapy, either PRRT that we want to do, and then you can deliver directly at the site, we say the linear energy transfer at the tumor cell. Either you can just home it and then you can do in many steps that you want to do the therapy. A similar way, the chemistry is very fancy. Those who are interested to really learn the biochemistry, either pharmaceutical, you can think about any biological molecule and we can really design the anchor to load it. And then you can have all these tracer for the application that we have been talking. With this, what you can do is that you have your target, you have the biological molecule, you can load the radionuclides by using different type of chelators that we talked about. You can do the alpha therapy, you can do the beta therapy, you can do OJ electron by using the indium-111. So this type of system you can utilize for the diagnostic as well as therapeutic application. And this is the summary of my entire talk that I talked about, that how we can design, how we can label, and how we can deliver it for this application. With this, I would really like to thank VRM, Sri Arvindo, and SAMS for getting me associated with this institute to develop this pharmaceutical. Thank you very much for your kind attention.
Thank you, Dr. Mishra, for your valuable input to the therapy and imaging both, because the future is like personalized therapy, personalized medicine, as well as we'll have to have a radioimmunotherapy rather than only the diagnostic. So it is extending the wings to from diagnostics to the therapeutics and as well as the personalized therapy. So it's going to yield a lot, and you say, it has been said that a lot of biomolecules also be they have to be involved into it, and then the therapy can be done. So a lot of innovation has to come. So I must congratulate you for this particular thing. What you are going to do is in the future here. And any question from anyone? So it was all chemistry, radio.
Biologically, why was fluorine chosen? So fluorine was chosen because you know that iodine used to do the iodination, means halogenation reaction with the biological molecule, and also it binds with the very nicely with the tyrosine. This was the first story started with this one. When we took the fluorine, the chemical density of fluorine and hydrogen is almost similar. So when we modify the biological molecule, we do not alter its biological property. So it remains as such. But the molecular weight is different. is chlorine 18 versus hydrogen. So chemical density we calculate only, not the perturbation of any. Like you take the ciproflox, you put the chloroquinone compound. It become more potent also at that time.
Thank you.
I request Dr. Vinod Bhandari sir to felicitate, to present a token of memento to Dr. Anil Kumar Mishra sir, former Director, Institute of Nuclear Medicine and Allied Science, DRDO, Professor, Department of Chemistry, IIT Roorkee. I request Dr. Sanjay Dikshit sir, DME SEAMS, to present a token of appreciation to Dr. Piyush Trivedi sir, former Vice Chancellor, RGPV, Bhopal. Thank you, sir. As we come to an end of today's session, I take this opportunity to propose vote of thanks. First of all, I'd like to take this opportunity to thank our chief patron, Dr. Vinod Bhandari sir, chairman and founder, SEAMS Indore. Thank you, sir, for your presence, endless guidance, support, motivation, and encouraging us throughout this CME. I express my sincere thanks to Dr. Manjushri Bhandari ma'am, Chancellor, SAU Indore, for her virtuous support and guidance. I extend our sincere thanks to Dr. Mohit Bhandari sir, Pro-Chancellor, SAU, and Dr. Mehak Bhandari sir, Managing Director, SEAMS, and Pro-Chancellor, SAU. Thank you for your support and constant motivation. I may like to express our sincere thanks to our chief guest, Dr. Jyoti Bindal ma'am, Vice Chancellor, SAU Indore, for her constant motivation, support, and for presiding over this function. I'd like to extend our deepest gratitude to all our speakers, Dr. Vikram Lele sir, Director, Department of Nuclear Medicine, Jaslok Hospital, Mumbai, Dr. Karuna Luthra ma'am, Director, Department of Nuclear Medicine, Sir H.N. Reliance Foundation Hospital, Mumbai, Dr. Anil Kumar Mishra sir, former Director, INMAS, Professor, Department of Chemistry, IIT Roorkee, for your highly informative and thought-provoking session. I express our sincere gratitude to Dr. Jayashree Thapadia ma'am, Dean Student Welfare, SEAMS, for her support and guidance. I extend our sincere thanks to Dr. Sanjay Dikshit sir, DME SEAMS, for his support and encouragement. I extend heartfelt thanks to R.R. Vavre sir, Dean SEAMS, for his support and guidance. We are also grateful to all the attendees to this CME, all HODs, doctors, healthcare professionals, students, for your active participation and enthusiasm. A heartfelt thanks to our organizing committee, whose efforts behind the scene ensured the seamless execution of the event. I take this opportunity to thank everyone associated with the CME. My sincere apologies if I missed out on anyone. Thank you all once again. There is an announcement here. The refreshment is arranged in the second floor, that is in Food Delight Hall. I request everyone to kindly join for the refreshment. Thank you all.